you.
Good morning, everyone. I'm Representative Kathy Abercrombie, co-chair of the Human Services Committee, and I'd like to welcome you all to our public hearing today, Tuesday, March 1st. Any opening comments from my co-chair, Senator Moore?
Just good morning. Looking forward to a great informational session. Thank you.
Thank you, Senator. Representative Case?
Good morning. Let's get rolling.
Sounds good. And Senator Berthel is probably in another meeting, so if he comes on, we'll give him the opportunity. Oh, here he comes. Let's just give him 1 second to connect. Senator Berthel, good morning. Any opening remarks?
Good morning, Madam Chair. My apologies for being a couple of minutes late. I'm, as we all are today, we're multiple meetings at the same time. I'm gonna have to jump right off, but no, I look forward to what I'm sure will be a very productive and healthy public hearing. You know, public hearings are arguably the most important part of what the work we do in the legislature, hearing the voices of the people we represent and their concerns. So thank you for a few minutes, and let's get to work.
Thank you, Senator. I couldn't agree with you more. Just a little bit of housekeeping before we get started. Just for people that are watching us on YouTube, if legislators seem to be looking in other directions, it's because most of us are on more than one meeting right now. So we're trying to coordinate between some of us 2 to 3 meetings at the same time. So we have devices in front of us. So if your head turns, it's not that they're being disrespectful in any way. They're just trying to do their job the best they can. So I hope everybody understands that as they're watching this. Secondly, I have the great honor of introducing our new clerk for Human Services. Her name is Cass Bruin Cassandra, which I love your full name, Cassandra. I know you go by Cass, but your name is beautiful. Cassandra is going to be our new clerk of Human Services and also my aide. And I just want to take this opportunity to welcome her. I know I speak for all of us when I say we look forward to working with her. She comes with best regards from public health, which she worked as, I think, an assistant clerk last year. And we're really lucky to have her. So welcome, Cass. I look forward to working with you. And I'm sure I speak for all my colleagues when I say that. So thank you for being here. And with that, let's get started because we have a long, not really a long agenda, but an agenda ahead of us. So with that, we will start with our first speaker, which is Commissioner Gifford. Welcome, ma'am, and thank you for being here.
Thank you, Representative Abercrombie. Good morning. You temporarily switched my branch of government, but I'll leap back into the executive branch for my testimony. Senator Moore, good morning. Rep. Case, Senator Berthel, and Cassandra, welcome. Look forward to working with you. I'm Deidre Gifford, Commissioner of the Department of Social Services. I am joined by a number of my wonderful team members from DSS, Nick Benedetto, our fiscal director, Peter Hadler, who oversees a number of the programs at issue this morning, Bill Halsey, our acting Medicaid director, and others, and they'll be here. Matt Antonetti, our director of legal services, to answer any of your more detailed questions. Madam Chair, shall I just jump in and go in order on our testimony? Is that your preference?
Yes, ma'am. Thank you.
All right. Beginning with HB 5040, the implementer to the governor's budget. Just by way of brief explanation, sections 2 and 3 of this proposal would transfer the community health worker program from DPH to DSS. This is a program that's supported by the Coronavirus State Fiscal Recovery Funds, CSFRF. I'm going to abbreviate that to ARPA in my testimony because it's hard to say those initials, but I think we all know it's the State Fiscal Relief Fund. The reason for this is quite simply because DSS has an existing relationship with the community action agencies to whom this funding is aimed. We've already, under a memorandum of understanding, transferred a little less than $300,000 and begun a grant program around community health workers. So this would simply move the remainder of the money to DSS. Section 4 it is again related to state fiscal relief fund funding of $10 million that was appropriated enacted in the last budget for nursing homes. That there was very specific language in the prior budget around the use for that funds. This proposal would broaden the use to allow us to use this fund for some extended rate relief, which we have provided to the nursing homes for the remainder of this fiscal year. Section 5 regards the minimum rate of $501 for intermediate care facilities and clarifies that that minimum rate is tied to the pandemic. The enacted budget included state funding of $1.6 million in each year to establish this minimal per diem, but there was an assumption that we would receive federal reimbursement. On further examination, that 501 minimum rate in a number of cases would mean that the state would be exceeding what's called our upper payment limit, and therefore would not receive federal reimbursement. So as a result, this section proposes that we shift those funds to one time the coronavirus relief or ARPA funds to cover those additional costs. Section 6 refers to our TFA program and was added at the close of the 21 session. This provision requires DSS beginning in fiscal year 2024 to provide cost of living adjustments whenever funds are appropriated, funds appropriated for TFA lapse at the close of the fiscal year. Our concern on this one is that this change results in potentially one-time lapsing funds being repurposed to support the ongoing costs of COLAs. We also note that Section 17B-104 of the general statutes already provides for automatic COLA increases without the limiting the administrative flexibility. So that section of 5040 is meant to clarify our position on that TFA lapse. Would you like to entertain questions, Representative, after each bill, or shall I complete all of the testimony?
I think it'd be better if you went through all the testimony
Okay.
and just open it up, because I'm sure my colleagues are making notes next to the ones that they want to ask questions. Thank
Will
you.
do. You're welcome. HB 5225, an act prohibiting clawback of certain funds retained by nonprofit providers of human services under contract with state agencies. The department does have some significant fiscal and administrative concerns with this proposal. We frequently use a strategy of paying these nonprofit providers by which we make an estimated interim payment based on costs. Then when actual costs are documented, we recoup the difference between the costs incurred, the appropriate costs incurred, and the estimated amount that was paid to the nonprofit provider. As written, the bill may expose the state to both federal audit and disallowance concerns, for Medicaid and for other federal programs. Section 1 of this bill would require any state agency that contracts with a nonprofit provider that provides human services to establish an incentive program to, quote, retain any savings realized by such nonprofit organizations from the contracted costs of services. However, as written, the department believes that it would potentially go beyond such an incentive and require us to not recoup funds that would be appropriately recouped under the terms of the program. So federal approval for our matching funds for many of these payments is specifically contingent on our ultimate ability to reconcile with costs. So the bill could prohibit the state from reconciling these costs and therefore could subject us to substantial risk of federal audit and disallowance. HB 5226, an act limiting state recovery of public assistance payments. This would limit recovery of public assistance payments by the state, except as required under federal law or court-ordered support payment. This bill primarily seeks to amend the state's public assistance benefit recovery policy to eliminate state liens and recoveries on cash assistance provided to parents of dependent children through AFDC or temporary family assistance. While DSS supports the intent of this proposal, we estimate an approximately $8.5 million cost, which is not currently included in the governor's budget. Therefore, although we can't support the bill at this time, we are amenable to working with all the stakeholders regarding a comprehensive assessment of the pertinent statutory provisions that may be affected by future legislative amendments. 5227, HB 5227, an act establishing the Community Ombudsman Program for home care. This would establish a program to respond to complaints regarding home and community-based services and supports analogous to our long-term care program for institutional residents. I would note that DSS did complete a report to the legislature that was submitted in January of 2020 regarding a community ombudsman, and we would be happy to reshare that report with members of the committee. The department appreciates the intent and purpose of this program, but notes that the current long-term care ombudsman program in the Department of Aging and Disability Services is supported through federal funding. No such analogous federal funding is available to our knowledge for a community ombudsman program. So we are unable to support the bill as the governor's budget does not currently include funding for the program. HB 5228, an act concerning the chairperson of the Autism Spectrum Disorder Advisory Council. This proposes removing the commissioners or the commissioner's designee as one of the three co-chairs of the council. The department supports this proposal. Our current tri-chair agrees that this would improve the functioning and the interaction between the agency and the advisory council. I would simply note that with DSS stepping back from the chairpersonship of this committee, we will need to work with you and other colleagues to establish the administrative support for the committee going forward. SB 195. This is an act increasing the minimum amount of assets that may be retained by the spouse of an institutionalized Medicaid recipient. It would require DSS to amend our Medicaid state plan to set the minimum community spouse resource allowance at $50,000. Just as a reminder, under current statute, community spouses of long-term care Medicaid recipients are allowed to keep 1/2 of the couple's countable assets up to the federal maximum of $137,400. The couple's home and one car are excluded from the assessment of the spousal assets. However, if the total assets are under $27,480, the minimum allowed by federal law, the community spouse may keep all the assets. This proposal would suggest that $27,480 be raised to $50,000. Our current policy, we would note, is in line with most other states and has been in place since 1989. We believe that the current allowable amount is fair and reasonable and supports the original intent of the 1988 Medicare Catastrophic Coverage Act, which sought to prevent the impoverishment of spouses of those applying for Medicaid coverage for long-term care. Therefore, DSS opposes the increasing the amount of assets protected for community spouses because of the fiscal impact to the state. Although it is difficult for us to collect asset information in all cases, we estimate a projected cost of approximately $4.5 million, in addition to the costs of system enhancements, and these costs are not recognized in the governor's budget. SB 196 is a repeat bill from 2021, which would prohibit discharges from nursing homes and residential care homes to temporary or unstable housing. DSS obviously shares the concern of policymakers who want to prevent individuals from being discharged to unstable housing. However, as we did last year, I would note for the members of the committee that in most cases, individuals who are being discharged from the long-term care facility have not met the level of care or level of need to be a resident of a long-term care facility. In those cases, and we have a formalized, standardized assessment that's done of every resident, in those cases, it is not appropriate for the individual to reside in a long-term care facility. And in addition to that, we are unable to claim federal match on any of the Medicaid-related costs for that individual because they have not met the level of care. We would, of course, welcome the opportunity to continue to work with the legislature, both on our Money Follows the Person program and on our newly developed with your collaboration CHESS program, both of which work to find housing, and in the case of CHESS, supportive housing for individuals who either are not appropriate or wish to no longer reside in a long-term care facility. So the department does not support this particular legislation. Finally, SB 197, an act concerning temporary family assistance. This bill would increase the maximum length of the benefit from the current 21 months to 60 months. Currently, most families in Connecticut who are subject to the 21-month limit become eligible for 2 6-month extensions if they meet the eligibility criteria, effectively creating a 33-month state time limit. Assuming Connecticut's average benefit duration would rise to the national average over time, we calculate that this change would result in an additional cost of approximately $5 million, which is not included in the governor's budget. The department appreciates the intent of this bill and is interested in working with the legislature to continue to make constructive changes to the TFA program, but are unable to support the bill at this time. Madam Chair, that concludes my testimony. I'd like to say thanks, if I might, to the team that's joined me this morning and all those working in the background for their hard work to summarize the bills and get me up to speed for this morning's testimony. Thank you.
Thank you, Commissioner, and thank you to your team. You really do have a great team there. So thank you to all of them for being here today. With that, we'll start with questions. Senator Moore.
Thank you. Thank you, Commissioner, and your staff. Always quite clear in your presentations. Appreciate that. I just have a question on number 5, the House Bill 5225. You said that it could prohibit the state from getting funds, matching funds. What's the parameters around that? Under what conditions would that happen that you would not get the matching? You're muted, Commissioner.
To clarify, Senator, you're referring to 5225 prohibiting the clawback of funds retained by nonprofit organizations? Okay. So in many of our programs, and in particular, this pertains to DMIS, DDS, and DCF, the way we make our payments is, and we estimate what it will cost for the private provider to provide those services over a period of time so that they can have the funds in advance. We provide those funds, and Nick and the team will jump in and correct me if I get anything wrong here. We provide those funds under the specific condition that at the conclusion of the period, we will recoup those funds that were provided in excess of the contracted amount. This has to do with the specific way Connecticut has historically provided funds to nonprofit providers. It's different from, say, a doctor's office who would see a patient, bill the patient for that service, bill the state for that service, and would be reimbursed. This is more of a advance payment based on an estimate, and then a process by which actual costs or services provided are reviewed retrospectively, and a recoupment is made. So under the circumstance where we didn't recoup for the excess funding that was provided to that provider, we would not be able to claim for a Medicaid match under those circumstances.
And why would you not recoup?
Well, it's our understanding that that's what the bill would require. It would require us under those circumstances not to recoup those excess payments.
Oh, I understand. You're saying it's counter to what you're allowed to do.
That's correct, Senator.
All right. Thank you, Representative Abercrombie. That's all I have.
Thank you, Senator. Representative Cook?
Hi, Madam Chairman. Thank you. And Commissioner, nice to see you. I have a question for clarification in regarding the Governor's H 5040 Section 4. When you talk about the expansion of dollars for nursing homes, my question is more of a question of concern when we recognize that there's been some, over the last several years, significant concerns with the nursing homes and not allocating dollars appropriately, not all, but some. Are we putting into parameters some type of oversight or reporting mechanism on the expansion of which we are allowing these nursing homes to utilize the dollars?
Representative, are you referring specifically to the cases where funds have been provided for raises and yes, and then not passed on to the workers?
Well, that would have been my preference. But as you were talking about, you had in your testimony, you said that there would be more dollars spent and there was an expansion of the utilization of those dollars. Are we restricting what those dollars could be utilized for? And if they are not, are they required to report back what the dollars go for?
Okay. In this particular case, the $10 million would be used for a 10% rate increase that was provided as part of our overall support of the nursing home industry over the course of the pandemic. That was slated to end at the end of March. And working with OPM, we extended that 10% rate increase through the conclusion of the state fiscal year. And that's what the governor is proposing we use this $10 million for. In this instance, Representative, it is not a targeted increase specifically for wage or pension. In previous instances of support that the state has provided to the nursing home industry, there has been a transmittal at the time that the funds were provided, specifically requiring the nursing home to pass that funding on to the workers. We have before this committee a proposal that would increase the penalties for those nursing homes that do not comply when we have a specific targeted rate increase such as that one. Does that answer your question, Representative?
It does. And I'm just hoping that we have more teeth and oversight, because I know that when we did this a couple of years ago, it took a significant amount of time for nursing home staff to get their raises, and the administration put the money into their coffers, and that was absolutely what it wasn't about. And I'm just hoping that if we're allocating more dollars, that we're following those dollars, because it definitely needs to go to people that are on the ground doing yeoman's work. And for all of those that are watching, I can't thank them enough for everything that they've been doing. So thank you, Commissioner, for the clarification.
You're welcome.
Further questions, colleagues? Really? Okay, my turn. So Commissioner, under the governor's budget, just for Representative Cook's knowledge and our colleagues' knowledge about the $10 million, this $10 million was put in the budget last year under ARPA dollars, and it was meant to stabilize the system. The formula that's used right now, the nonprofit nursing homes were getting paid a lower rate. This was to bring them up to the same rate as what the for-profit nursing homes were getting. So that's what that $10 million was supposed to be used for. Through the budget cycle, the DSS has been working with the nursing homes on a new payment system, which is called acuity-based system. Because they've worked it out with the nursing homes, and this is going to be a 3-year formula to get to that new payment system. We had talked to them about this $10 million still going back into the nursing home system to help them be stable throughout the rest of the year. So just for clarification, this isn't the ARPA dollars that we had allocated to go into salaries for employees. So if an employee they feel, say is in IT and needs to get a bump up, they can use these dollars. So just for clarification, that's what that meant. I hope that's helpful. Commissioner, Section 5 of the governors with the ICF for the 501 for the day rate. Just for clarification, that wasn't, the intent was not just for the pandemic relief. The intent was to keep that as a permanent rate increase. So just as we're talking about this, I just want people to understand when we did the budget and this was put in the budget, it had, yes, the pandemic was part of it, but it was also the fact that they hadn't gotten an increase for years. So I just want people to understand that even with the pandemic, us getting in a better place, that rate increase, we'd like to stay in there. On the clawback, House Bill 5225, I have to tell you, I'm really surprised by your testimony. This has been current law for over 3 years now, and now all of a sudden, you're testifying that it could put us in jeopardy of federal law. That was never the testimony over the last 3 years. The reason why this is back here this year is because the judicial branch had decided that they weren't included in this legislation that we've been working on for over 3 years. And that's why we had to bring this bill back again to include them. We found out from human services providers that provide services to the judicial branch that the judicial branch told them they did not have to honor this legislation. I personally think it's a slippery slope. I don't remember us ever doing legislation that only included one branch of government, but you know, this is what judicial said. So that's why this is back. So I'm really, I'm surprised by your testimony on that, but I will tell you that I'm willing to work with you on this. If we've missed some steps in what the intent was, I think I would be more than happy to work with you on this, but I think we're looking at this differently, and this has nothing to do with Medicaid reimbursement. So I think we need to have a further conversation on it. The Community Ombudsman 5227. My understanding is that there is opportunity for us to get reimbursement for this position from the Fed. My understanding is in some of the federal dollars that haven't been allocated yet, but are on their hopefully way, that we will be able to get reimbursed for this position going forward. So I'd love to be able to keep this on the radar. And if we have to supplement it right now with perhaps maybe some ARPA dollars, I don't want to speak for the Commissioner of Aging and Disabilities, but she got some pretty good money over there. So it might be an opportunity to use some of the money for this position. And I think the time has come, and I know this is a little outside of your lane, but I think the time has come for us to look at our ombudsman program that we have. And I think that we should have someone like Mairead as the director, and then perhaps like deputy directors under her that do the hospice and then also home and community based. So just kind of keep that on your radar, and hopefully the feds will also follow with that. So that's the intent of that. And then for the autism, the 5228, our thought on that is that there would be a liaison from DSS, not who is the current co-chair of the committee, only because her workload is so heavy. It's not in the best interest to have her there, but I think that our liaisons for human services could have a seat at the table. We have other agencies that are already at the table. So that's kind of the intent of that. We're also doing it on the Deaf Community Advisory Council also, because I think it puts the agencies as a co-chair in a really difficult position, because they're not at liberty to be able to support certain initiatives without getting it okay by their bosses. So just so you know, we still want a liaison position in there. On Senate Bill 195, which is to increase the spousal, the only thing I'm going to say about this is the feds go to 137,000 is the allowable that a spouse is able to keep, right? And here in Connecticut, we know that it is an expensive state. And I think we're doing our seniors a disservice with just going to the 27,000 that is currently the allowable amount. 50,000, I don't believe is going to make any of these poor seniors rich. I just believe it's the right thing to do. So we will, still be pushing to go forward with that. SB 196, which is the discharge. So this really isn't so much around nursing homes. And I get what you're saying. You can't keep someone in a nursing home if it's not appropriate care. But on the flip side, you can't transfer somebody out of a nursing home if there is an appropriate care place for them to go. This was really more around residential care homes and what's going on there with the discharge. And I know that there's a lot of work right now behind the scenes, which I know we're going to have a presentation on this around in MAPOC, around residential care homes and what role they play in the state. Should they be getting Medicaid reimbursement? So, it was really the residential care homes that we were most concerned about with that bill there. And I think that's it. So I just wanted to make those comments for you to kind of understand the intent of some of this legislation, since we haven't had a conversation about it. I do appreciate you and your team and your comments on these proposals. And again, I look forward to working with you and your team as we move forward. Any other questions or comments from my colleagues?
Representative, if there are not, may I offer one additional comment on the ICF rate?
Sure. Yes, ma'am.
I appreciate your clarification of the intent. I do want you and the committee to be aware that that rate will exceed the upper payment limit for this provider type, which is something that we and all Medicaid programs strive to avoid, not only because we don't get federal reimbursement on those costs that are above the upper payment limit, which is obviously significant, but also because we end up paying providers. And in this case, there are some providers whose reimbursement actually exceeds their documented costs. So we would be happy to continue to work with you on thinking about appropriate adjustments for this provider type. But we are very concerned about a rate that exceeds documented costs and exceeds the upper payment limit, which is really make this quite different from any other payment strategy that we have in the Medicaid program. So happy to discuss this further.
Yeah, and I thank you for that. And I think for clarification, in layman terms, what you're saying is, right, and I'm going to call it reasonable and customary. So the feds say, hey, an allowable expense day rate is $401. Connecticut feels that we should go to $501, and the feds say, nope, we're not going to do it. So is that kind of in layman terms accurate as to what happened in this particular situation?
It is, and the reasonable and customary reference point that they use is generally what Medicare would pay under equivalent circumstances. So that's the benchmark that the feds use when we have to do an so-called upper payment limit calculation. That the basic federal premise is Medicaid programs may not reimburse and get federal funding in a way that would exceed what it would cost if Medicare were actually paying.
Yeah, and I think that's important because I don't think that for people that aren't on appropriations, don't understand that there is and I'm going to use the alphabet soup, UPL, which is upper payment limit. So if they ever see that, they'll know what that means, that even though we feel that providers should get paid a certain amount, we still have to adhere to what the feds are going to give us, which means if we go above that, it's all state money. And in this case,
Right.
that's what's going to happen. That's what's going to happen. Now, having
Correct.
said that, we as a body, and when I say we as a body, most of the appropriations feel that it's money well spent out of the general fund, they will decide to still carry this forward. So, I do appreciate what you're saying, and I think it was helpful for my colleagues that may not be on appropriations and don't understand how the budgetary parts work. So thank you very much for that clarification. I still don't see any hands raised. So with that, I'll thank you, Commissioner, and your team for your testimony today, and look forward to working with you in the future, and have a great day.
Thank you, Representative. Same to you. Thanks, everyone.
Up next, our next commissioner, Commissioner Amy Porter from Aging and Disability Services. Good morning, Commissioner.
Good morning, Representative Abercrombie. Good morning, also Senator Moore, Senator Berthel, Representative Case, and distinguished members of the Human Services Committee. My name is Amy Porter, and I'm the Commissioner for the Department of Aging and Disability Services. I am joined here today by Andrew Norton, our legislative liaison, and Margie Gerando-Marquette, who is a manager in our state unit on aging. We're here to talk today about the House Bill 5231, an act concerning data collection to prevent malnutrition among senior citizens. And we want to thank you for the opportunity to offer testimony. We agree with the underlying motivations behind this bill. The pandemic was a clear reminder for all of us of the importance of our nutrition programs in the lives of older adults here in Connecticut and across the country. And I cannot express my gratitude enough to our staff, our community providers for the work that they did to make sure they could respond to the pandemic. And we really want to make sure as we move forward that we have the best information available. So we understand that that's the intent of this bill. We do have a few recommended changes, and they are detailed in my written summary. So I'm just going to summarize here. First recommendation is to remove what we see as outdated references to NAPIS, because that has been replaced at the federal level by a reporting system called the Older Americans Act Performance Systems. That system does collect nutritional risk information through an assessment called Determine Your Nutritional Risk, and that's the federal program that we use for a reporting system now. In addition to this federal data, as you know, we've had a lot of conversations about additional data collection. We did add a new section on October 1st to our state data collection form. Many of you in years past may have heard us and our stakeholders talking about the Form 5, the consumer registration form. So we did add a new section to the Form 5 in response to the federal focus on malnutrition, our own state plans, objective addressing malnutrition and food insecurity, and the concerns that we've heard from our partners throughout the past couple of years, and particularly in some of these hearings in the past. I had this backwards. So we do want to just recommend changing the NAPIS piece and making sure that we can update that. Also, while our department does sympathize with the burden that's placed on some AAAs and ENPs, our elderly nutrition providers, in delivering meals to rural areas, less densely populated areas, The recommended change about including that rural piece and really highlighting it, we're concerned because it's one of only several factors that we already take into account when we determine our formula for distribution of nutrition funds. We're worried that if we single out and elevate the rural factor for the first time in state statute, it could disrupt the careful balancing of factors that are required of us under federal law. So any advantage or added weight given to rural factors might have to come at the expense of other factors like disability, like minority status, like low income status. And so we request that this language be removed because it's already part of our formula calculations. And then third, there's a report that's required as a result of this legislation. And we just ask that the deadline for producing that report be changed to July 1st, 2024. That will give us the additional time for systems development, for data collection, and for pulling all the information together and providing that to the legislature. So again, there's a lot more detail in the written summary, but we wanted to provide some of those basics for you, and we appreciate your consideration of the changes. We will be interested through the course of the public hearing today to hear the perspective of our partners, specifically on the data collection efforts, because we do see that the reporting requirements will create additional work for both the area agencies on aging and for our elderly nutrition providers. So hearing their perspectives and being able to balance that, we're really interested to hear what that looks like moving forward. So thank you for your attention to this critical topic and for allowing me the opportunity to offer testimony. I look forward, as I know my staff does, to continuing to work with you on this important matter, and happy to answer any questions that you may have. Thank you.
Thank you, Commissioner, for your testimony, and thank you to your staff for being here. Opening up to questions, Representative Hughes.
Thank you, Commissioner, and thank you, Madam Chair. I'm just wondering, I'm sorry I did not review your written testimony yet. Did you have any suggestions about modernizing, making the data collection really user-friendly and not so much of a burden? Is that part of the system upgrade that we're proposing?
Margie, do you want to speak to that at all? And if you don't have the information, so just full disclosure here, many of you have worked with Stephanie Marino over the past many years on our nutrition program. Stephanie's really been our lead on that, and she just retired. So congratulations to her. She's done incredible work. And so her boss, Margie, is here today. So Margie has been, she's been following this all along and actively involved. But if we don't have exactly the details, Representative Hughes, we'll get back to you. But Margie, I'm going to toss that to you for a minute here.
Sure. And some of the data we do collect, and it's new though, so we have to set up a system to then properly analyze it and then put it into reporting. I think what we want to do is take a look at the details here, because some of the things we don't currently collect at the state unit on aging level, it's collected at the AAA level. So we'd want to be able to figure out, how do we get it? How do we analyze and report it? And then it looks like there are some new items that we'll have to collect as well. I think with what's in here, we would have to work with the ENPs, the AAAs, and our data staff. We have one data staff person to put together something that would work for everybody. And we'd probably have to update our system as well, as Commissioner Porter said. So there would be certainly some work involved in the added data collection.
Thank you for that. And does that factor into your recommendation of pushing out the deadline for reporting?
Yes.
Okay. Thanks, Madam Chair.
Thank you, Representative. Representative Cook.
Thank you, Commissioner, and thank you, Madam Chairman. I just have a really quick question, maybe not really quick. So, Commissioner, as you know, that this is the exact same data collection bill that we had worked with over the last, year or so, that died in the Senate actually last session. And it was a piece of legislation that you were actively involved in our negotiations. We never had a conversation last year discussing the pushback of the data collection and the reporting. And so I'm wondering why now we are requesting a pushback of data collection. And I think it's valuable to say that the recommendations came from the providers that are on the ground. for anybody that's actually listening. And those are the ones, I think those are the folks that we should be helping and assisting. So, I guess there's a concern for me because it's not something that, I mean, you've been around long enough to know that this would have been coming back as it passed the House and died in the Senate. So why the pushback, and how do we make sure that we don't have to see that pushback? Because at the end of the day, this is something that's been worked on now for a couple of years.
Yeah, thank you for the question. And we just were acknowledging that we know that there's going to be some time where we have to do systems changes. We're going to have to go back to our contractor to make sure that they're able to pull all the information that's required for the report. We have already implemented changes to our Form 5, so I feel like we're in good shape to be able to collect that data to move forward. We have the federal data, so it's just these new pieces being able to change our system to be able to move forward. If we need to do the report, we can. We were just trying to buy the time to make those systems changes, make sure that the data collection efforts really lined up with what the elderly nutrition providers and our AAAs were looking for as well, and working with them on that. So I do appreciate the question. We would appreciate the extension of the time. If not, we will work together to get you as much of that data as we can.
Yeah, because my understanding is the data is collected. It's just about putting it into a different type of reporting mechanism, correct?
My understanding is that some of that data is available now, but not all of it. So what we've done in the Form 5 has now changed, and that's all being collected. What's available through our Older Americans Act reporting system is available, but some of the other components that are asked for in the report are things we're going to have to work to collect and be able to analyze. That's my understanding. Margie or Andrew, do you want to add to that?
Yes, that's correct. And in the bill, it says making some comparisons. So those are things that are not currently in place. And as Commissioner Porter said, this is something that we can do and put in place. And we would work with the AAAs and elderly nutrition providers to make sure that we're getting at what you're looking for here. But there are some additional steps that we have to take. They can be done. That was why we were looking for the additional time.
So I think what saddens me is you all know that, as again, I say, being around this building long enough, just because something dies one year doesn't mean that it's not coming back the next year. And, the longer we continue to push the reporting mechanisms back, the longer that the funding distribution and all of the information that we're looking for to utilize in a better manner, and quite frankly, to be able to access more federal funds, just goes by the wayside. So for me, as much as I understand what you're saying, I'm a firm believer that work should have not stopped on this conversation, that it should have continued to move forward. So I would really like to see us not give the extension. And that is not a disrespect to you all, but it is really about listening to our providers and making sure that they have everything in their power that they need to do the best that they do. And they too do incredible work on the ground to make sure people have everything that they need. It's not that I don't appreciate the good work that you all do. I just think that there's a manner of which we can move this thing forward, because it would have been already in law, again, had it not found a hiccup upstairs. So I'm just, truly in favor to move things to the manner of which we had recommended. But I respect your position, and I want to thank you all. Thank you, Representative Abercrombie.
Commissioner or Madam Chair.
Sure, Andrew.
I did want to, I think the commissioner mentioned this, but I wanted to underscore that just this last fall in October, the State Unit on Aging created an entirely new section to their data collection form on elderly nutrition. And just to nod ahead to Representative Cook, that was in no small part because of this push for increased data collection that's come from you and colleagues. And the people you represent. So in fact, just this last fall, the department and the state unit added a whole bunch of questions to gather more information, in part because the federal government would like us to be doing more of that, but in no small part because of the push coming from this legislature. So even though the bill didn't pass, we did add an entirely new Section 7 to the data collection form to enhance nutrition data. So we've actually been paying a lot of attention to what the legislature wants and have taken some actions in that regard.
Thank you for adding that, Andrew. And we were able to, once we added that, we had a joint meeting with our AAAs and our elderly nutrition providers to talk about that. So they're aware of it and using that at this point.
Thank you, Commissioner. Thank you, Andrew. Any further questions or comments? Seeing none, thank you so much for being here today. We appreciate it. Have a great day.
Thank you all.
Up next, Commissioner Yutani. Good morning, Commissioner. So nice to see you. First time before Human Services. Welcome.
Thank you very much. Appreciate the opportunity to be with all of you today. And I would like to take this time to support House Bill 5040, which implements the governor's budget recommendations for human services. And these proposals include behavioral health services and practitioners to the student loan repayment program in order to expand access to needed health care in underserved communities. So I really want to thank you for the opportunity to testify on this very important issue. The student loan repayment program will support primary care providers working in health professional shortage areas to meet healthcare workforce needs within Connecticut and assist in meeting the following long-term goals: increased access to primary care services and behavioral health services, decreased healthcare disparities, and improved overall health outcomes in these vulnerable communities. Access to primary medical, behavioral health, and dental care is an important prerequisite for good overall health. And a lack of primary health providers creates access barriers for low-income, publicly insured, uninsured, and geographically isolated residents. In Section 1 of the bill, the student loan repayment program directs service programs to be inclusive of behavioral health services. This was not there in the past, and expands eligibility through redefining primary care clinicians to include psychiatrists, psychologists, licensed clinical social workers, licensed marriage and family therapists, and licensed professional counselors. By improving access to mental health care, we are improving all of the opportunities for student loan repayment programs. Since the onset of this pandemic, there's been an increased demand on mental health care in Connecticut that has not been met. The United States Surgeon General has declared a nationwide childhood mental health crisis, consistent with the challenges that we're seeing in our state, and I applaud the legislature for trying to address. And financial assistance to help behavioral health care professionals repay student loan debt will promote a diverse workforce that addresses the critical service need. So thank you for your consideration on this particular issue, and DPH encourages committee members to reach out with any other questions.
Thank you, Commissioner. Thank you for being here. Questions, colleagues? Seeing none, I have one question for you, ma'am. So my understanding is this is a program that is offered through the federal government through the FQHC. Do we know what the matches from the federal government with the amount of money that we're given in? So is it like a 50% they match us to our dollar? How does that work?
So I'm actually going to ask Miriam Miller if she can comment on the specifics of this, since she's really become our subject matter expert on this. Miriam?
Hi, my name is Miriam Miller. I'm a Special Projects and Policy Manager at the Department of Public Health, and also acting as Legislative Liaison with Jill Kennedy. The student loan repayment program, as described in this legislation, is funded by ARPA dollars, the American Rescue Plan Act, and the governor is proposing using $17 million over 3 years to fund this program. So there won't necessarily be an exact match, and there's no match required from the state funds as well. There is a HRSA grant opportunity that we'll be applying for as well to provide additional funding to the program. But again, neither funding resources require a federal or state match, but are federal resources.
So let me back up a little bit. So are you saying because it's ARPA dollars, we don't get a match from the federal? I'm not talking Medicaid dollars here. My understanding was that this was a federal program that had been in existence for a lot of years. And because Connecticut, and you know, I've been here for over 16 years, so I've done a lot of budgets, we've had some really lean years, and we haven't been able to contribute to this program. So are you saying because we're using ARPA dollars, we're not going to get any kind of match from the Fed?
So the ARPA dollars are coming from the federal government. So it is kind of fully federally funded through ARPA.
What I would add also is that this is going to be like new infusion of different money than what we're traditionally used to getting. So, I want to clarify that because I think the program you're talking about is something that has always been in place. This is an additional infusion that is separate and apart in a sense of what has already been standing there, and that does go through those fluxes.
Thank you for that clarification. I think that's helpful. I wasn't thinking of it from that lens, so thank you.
Right.
Because I think as we go through the appropriations budget, which I'm on appropriations and I do your subcommittee, Commissioner, I just want to make sure that we all are talking about the right amount in dollars. So thank you.
Exactly.
For that.
Yeah, and if I can just add one more plug for that, that's why we are so excited about this 17 million, because this is different and apart. This is putting an investment on the part of the state saying behavioral health matters. The providers that are making a choice to go into a field where they know that reimbursement is lower than other fields, we are there, we have their back, and we're, as a state, saying that we're going to help you get through your training and what you need to do to provide this critical resource. This is an additional infusion that really is making a dent into what those providers take on in terms of the debt that they have.
And I couldn't agree with you more. So just for clarification, so this isn't only going to be offered to FQHCs. This is going to be any student that goes into this field.
That is correct.
So
That's great, because I think there was some misinformation, and it was probably me getting two pockets of money confused. So thank you for that. I think that's great. I think it opens up the field, which is what we all want.
Right. Miriam, did you have something you wanted to clarify in what I said?
Yeah, Rep. Abercrombie, I was just going to add that it's the funds will be directed to people working in health provider shortage areas. Naturally, that is going to mean that it's going to go to a lot of people working at FQHCs. But if we've learned anything through these designations, that it's not just FQHCs, it can also be hospital systems that serve these catchment areas as well.
Yeah, no, thank you for that. And I couldn't agree with you more, right? It doesn't prohibit anyone outside of FQHCs, but you're right. The need in the FQHCs has grown so much, especially through the pandemic. So thank you for that. Representative Aurora.
Thank you, Madam Chair. Just a quick question, and thank you, Madam Commissioner, for testifying on this. Just a quick question, since this program is being funded, this additional idea is being funded by ARPA dollars at this point, are you thinking about this as a stopgap 3-year or 2-year program to be discontinued after that? Or are you thinking this is what we're going to kind of pilot it with and later after that find other dollars elsewhere to continue it?
Yeah, so I mean, I do think that this is in some ways time limited, right? Because it is an infusion, but our goal would be to see that we make a dent in the workforce shortage, in our behavioral health response in our state. And if we start showing that this is successful, that yes, our goal would be to continue such a thing. But I think it's really going to depend. And we look to all your partnership to be able to help support that going forward.
And I would
Thank you.
Oh, sorry.
Yeah.
I'll just really quickly add that there's additional funding opportunities through HRSA that we're going to continue to monitor. So hoping that will help make the program sustainable past the ARPA availability.
Thank you very much. And Madam Chair, one other quick follow-up. the spending, is that there are two kinds of ways to stimulate what you just said is as the supply side. One is structurally benefiting programs, which is training or things of that sort. And the other is just paying more, which is in some sense a zero-sum game, because you can pay more and then some hospital or somebody else is going to be unable to have that person. That could be some degree of inflationary process, which we obviously are seeing in the last 18 months, primarily because of ARPA and infusion from federal programs. So are we focused more on structural factors, or is it going to be just, let's just pay more so that we can attract more people that way to those specific ways, to that specific program? I hope you see what I'm going at here.
Could you clarify, when you say structural factors, can you clarify what you mean by that in terms of the structural factors?
Yeah, in terms of structural supply side factors involve, really training, attracting people, having more folks attracted by making them prepared. Typically, it's training as well as some degree of creating institutions or supplementing programs which really long-term attract people to that particular provide that supply. Structural factor, create a factory. Yeah. Now you got production. A cyclical factor is you just basically give more money to the current manufacturer, and it's easier to think about it in a manufacturing standpoint than in a standpoint.
Yes, no, I understand your question now better. So I think this is an all hands on deck approach. You can't use just one method to try to solve this problem. So I think we are in complete alignment how we see this issue. So working with the Office of Workforce Strategy, working with the Office of Higher Education, working with our educational partners throughout the state, whether it's CSCU or others, looking at that pipeline of how we are going to attract more people to come to train in those specific fields. And then, in addition to that, offer this financial assistance to help reduce the burden of having gone into those fields. And then looking at it from a more holistic approach, trying to attract people of various different backgrounds so we make sure that our workforce looks like the patients that they're caring for. That is really sort of an approach that we're taking in improving the throughput and the workforce in this particular area.
Thank you. Thank you, Madam Chair.
Thank you, Representative. And just for a clarification real quick, I hope that we're also looking at the educational opportunities. So we know that for nursing programs, there's about 7,000 students that couldn't get into a program. I'll be honest, I don't know a lot about these fields, but I hope as we talk about this, we're also looking at the amount of teachers that we have out there, and is there an opportunity to change that system at the same time, right? Because we can't be in silos of just public health promoting this, which is great, if we're not also connecting to the educational piece. So I think we need to keep our eye on that also.
100% agree with you. And I would say that one thing that I have seen in joining this administration and doing this work is that there is so much collaboration across the different sectors so that we are not in our silos. So that's why I bring up the Office of Workforce Strategy. So as people are graduating from programs, how can we bolster that relationship with the partners who are going to hire them? How can we help get them through their programs, have that training platform so that they can have security of a job coming out of it? And we have healthcare partners who are interstate, who are working with the Office of Workforce Strategy to be able to create that pipeline where they're basically getting guaranteed a job at the end of their training program. Second would be, for example, Office of Higher Education. We know for some of these nurses and other trainees, students, they've had a hard time getting their training that they need because in-person training was limited in different areas. So working with those groups and working with the Office of Higher Education to say, okay, these students who are coming through these various different programs, whether it be medical assistant or nursing or nurses aides or a variety of things, how can we help that throughput again so that they can get to the point of getting a job? So I think that's exactly what we're trying to do. And, that's why I brought up the educational partners, making sure that the various different educational partners, whether it be through our state schools like the CSCUs or otherwise, or our private partners, to be able to help in that regards. That's why it really is all hands on deck.
Thank you. I couldn't agree with you more. Seeing no further questions or comments, I want to thank you for testifying before Human Services for the first time. And Miriam, it's nice to see you in person. I know we've had a lot of emails back and forth over the last year, but thank you so much for being here and have a great day.
Thank you so much.
Moving on, and I'm going to call everyone, even if they're not here this way. If they come on later, we can just move them up in it. Senator Kelly? I don't see Senator Kelly. Representative Johnson? I don't see Representative Johnson. Our Ombudsman, Mairead Panter? There she is. Good morning.
Good morning. How are you?
I'm great, thanks. How are you?
Excellent. Thank you.
Representative Johnson, we're going to let Mairead go and then we'll call you, okay?
Okay, thank you.
Go ahead, Mairead.
All right. Good morning, Senator Moore, Representative Abercrombie, Ranking Members Senator Berthel, and Representative Case, as well as all the distinguished members of the Human Services Committee. I'm Mairead Panter, the State Long-Term Care Ombudsman, and I've offered some written testimony, but I'm also happy to testify regarding several bills before you today. As the State Ombudsman, it's my responsibility to facilitate public comment and represent the interests of residents in Connecticut's skilled nursing facilities, residential care homes, and managed residential communities. The first bill I would like to talk to you about today is SB 196, an act prohibiting involuntary discharges from nursing homes and residential care homes to temporary or unstable housing. The Long-Term Care Ombudsman Program supports a prohibition on discharges to temporary or unstable housing. Residents should only be discharged to situations where they can receive supports necessary to stabilize their situation and provide for their overall well-being. The lack of stable housing and follow-up services for discharged residents has resulted in many of these individuals returning to the hospital with higher levels of medical care needs or facing re-institutionalization. Residents have the right to be discharged to a safe setting unless it's an emergency. It should be planned and meet their individualized needs, as well as include access to stable housing. Not providing this stability puts the individual at increased risk and increased demand on the overall system. We observed this most recently when the governor lifted the temporary ban on involuntary discharges. We began to see individuals discharged to hotels or shelters. The outcome of some of these discharges resulted in hospitalizations and reinstitutionalization, as well as further medical complications. We need to ensure that there are better systems in place for appropriate planned discharges for all people. The second bill that I'd like to comment on today is HB 5227, an act that establishes a community ombudsman program for home care. I want to thank you all for the careful consideration of the expansion of the long-term care ombudsman program to include community-based services. I support this as long as we heard earlier, there's appropriate financial support and appropriations to do so. For years, individuals in need of long-term services and supports have been told that they have the right to choose the setting in which they receive such supports, and this should include the support from the Ombudsman program. When choosing to receive LTSS services in the least restrictive environment, an individual doesn't have less need for advocacy and support. In fact, I'd argue that they have a greater need at times. Our program offers an autonomous, unbiased, person-directed approach that ensures that individuals are fully informed of their rights, have access to available resources, and the ability to self-direct or be supported in a way that helps them achieve the highest quality of life. I also believe that having a community ombudsman program within the already established long-term care ombudsman program will allow individuals to stay connected with their regional teams, and they're already familiar with them, so this will just further support their ability to have services. Currently, when we receive a phone call from an individual who's living in or is transferred to the community, our program is not able to open a case or assist them. We must work to try to find another provider or service that might be able to assist them. Many times there isn't another resource available to help in this way. This is very challenging and frustrating for the individuals that we serve. Having a community ombudsman program will allow us to support the person receiving long-term services and supports in the setting of their choosing as they navigate what can be a very overwhelming system. So I thank you for this opportunity to present this to you today, and I'm available if there's any questions.
Thank you, Mairead. Thank you for being here today, and thank you for your testimony. Representative Hughes.
Thank you, Madam Chair, and thank you, Mairead. Let me, on behalf of the entire committee, thank you for your, heroic work during this pandemic and beyond. I want to ask you specifically, I know you're in support of this, but we also talked in, the Oversight Council about bolstering the staffing for your office, quite frankly, just even within the long-term care. Do you have any recommendations in terms of this bill, in terms of adequately staffing and giving you resources for the kind of oversight that you need, as well as recommendations, again, financially, about what that would look like for a community-based ombudsman office?
As Commissioner Gifford submitted, we do have an initial report that was done 2 years ago that goes over some of the financial support that would be needed. The support from my office, yes, we have increased our caseload dramatically. A number of years ago, I think in 28, we went from 9 ombudsmen to 8 for our long-term care communities, and that continues to be a struggle. But as far as the community ombudsman goes, we would need the support. I saw the projections that are in the bill. I believe that is a good starting point, and we'd have to see the types of referrals we got.
Right.
When we knew what we were receiving, then we would be able to look at the needs, but having the structure in place to have the support in our office in the different areas of focus, I think would be very important.
Okay, if you have any details about that that's not already in the testimony, I presume Representative Abercrombie would welcome that as we go forward into appropriations. Thank you.
Thank you, Representative. You're absolutely right. Any help we can get with, we do appreciate. So thank you. Any further questions or comments? Seeing none, thank you, Mairead. Have a great day and look forward to working with you in the future.
Thank you, you as well.
Representative Johnson, we have to go to the public real quick because we're past our hour. So
Okay.
First up is Anneli Reed. Anneli, are you here?
Yes, I am. How are you?
Good, how are you?
Good, thank you. Senator Moore, Representative Abercrombie, and distinguished members of the Human Services Committee. My name is Anneli Reed, Administrator of All Point Home Care. I am testifying today regarding Bill HB 5040, an act concerning the governor's budget recommendations for human services. All Point Home Care offers a variety of home care services, including intermittent skilled care for medication management of adult and pediatric patients. Mental illnesses are significantly increasing, and so is the prevalence of chronic psychiatric patients. As a result of this increase, chronic psychiatric disorders impose a significant burden to patients and their families. Home health care services for medication management can significantly reduce the burden on the patients, their families, and the health care system. Adding to the impact of mental health illnesses often results in patients having trouble managing their medications, which may lead to non-adherence, resulting in emergency department visits and hospitalization. Home health care can significantly reduce the cost of managing these patients at home while improving their quality of life. In addition, home health care minimizes the burden on outpatient services and supports a more independent life for the patient and the families. Medication management can also benefit children with medical conditions such as diabetes. All Point Home Care currently has a specialty program addressing the needs of diabetic children that are not adhering to their medication regimen. We work closely with that involves strict diabetes and medication management. Psychosocial considerations have to be made for these clients, as there are often barriers that limit the ability for the patient to achieve success in their diabetes management. By providing daily home health skilled care, the client is able to manage their disease consistently, which helps them gain control of their blood sugars, lowers A1C, and prevent hospitalizations. Another cost savings as we help to keep the patients out of the hospital. In order to deliver these services to our behavioral medical health clients, we need qualified, skilled nursing professionals. The role of the nurse that provides these services is very complex. The clinician must have a strong knowledge base of caring for the behavioral health client, as well as the action, side effects, and potential interactions of medications. During each skilled nursing visit, the nurse evaluates the patient's mental health status and the efficacy of the medication being administered. However, our resources are limited due to the low reimbursement rate for these services. Our agency currently has a higher percentage of patients needing services than the availability of staff. We cannot compete with other care providers who can pay more and offer better benefits. In 2016, the home health medication administration rate was cut by 15%. The recent ARPA funding has invested 4.5% back to the providers, leaving a 10.5% shortage. Given the rise in mental health illnesses and the inability to hire qualified nursing staff due to inability to compete for salaries, we are here before you respectfully asking you to consider increasing the medication administration reimbursement rate by 10.5%. This increase will be invested directly to the workforce by increasing wages, offering competitive benefits, providing extensive training and oversight, and retention.
Excuse me, your 3 minutes are over. Can you please summarize? Thank you.
Sure. No, I'm done. I just want to thank you for the opportunity to provide testimony, and you can feel free to contact me if you have any questions.
Thank you. Thank you for your testimony. Any questions, colleagues? Seeing none, just real quick, Anelli. So just for clarification, when we did the med administration cut, that was a deal that we made with the association to add another level of education to try and save money. So when you talk about the cut, there was a cut, but it was an agreement. And we also carved out mental health as being one of the fields that would not be included in that new level of education. So, you know, when we talk about this, I want my colleagues that have not been here as long to understand that it wasn't that we just came in and did this cut. There was a lot of negotiations with the association that went on. I'm not saying that they don't deserve an increase. I just want it to be in perspective as to what was done back then. And that was probably maybe 10 years ago that we did that. So thank you for your testimony. Any questions or comments? Seeing none, thank you so much. Have a great day.
Thank you. We're going to go back to the elected officials. Representative Johnson.
Thank you so much, Madam Chair. I much appreciate it. And thank you so much for raising the Senate Bill 197 and act concerning temporary assistance for needy families. This is a very important bill to my community and many of the communities that we that serve people that have homeless shelters. And in my district, I have 3 homeless shelters, as I'm sure many people have already heard me state that. I have 3 homeless shelters that address the problems that people have when they're living in poverty. The temporary assistance for needy families came into effect back in 1996 when we once had the Aid to Families with Dependent Children. That program was providing services to poor people, poor families. When they needed the services, they could have it until the child was 6 years old and in school. When the Temporary Assistance for Needy Families was passed into law in 1996, it put a limit of 60 months on the access to services for poor people. So when that happened, there was a real concern by many people who were supportive of women and children receiving the care that they need to make sure that they don't end up homeless, to make sure that they don't have to stay in violent relationships, to make sure that they have children that are going to be in stable housing with a stable income, that those kinds of problems would occur. So there was a lot of testimony on the federal level to to address that. Nevertheless, the program passed and it eliminated the aid to families with dependent children, and the temporary assistance to needy families went into effect. And then subsequent to that, Governor Rowland limited access to for families to 21 months, when the actual access could be up to 60 months. It is a block grant. It's no longer an entitlement program. So there are certain things that can be provided to families. However, the limitation, we're second to Arizona only in terms of the limitation and access to funding for families who are poor. And so with that said, and being in legal services, looking at the differences in my community, since aid to families with dependent children was changed to TANF and then reduced to 21 months, I now have 3 homeless shelters, one for domestic violence and one for families. I still have not received an answer to what happens in the Holy Family Shelter when we have a male child who is homeless with a family and he becomes an adolescent, he no longer has access to a shelter, and he's not allowed in the no free shelter. So I'm not sure what happens to male children in that circumstance. We have, just to give you another idea of what kind of a community I represent, which is a wonderful community. We have so many different things here, but in terms of the people who have limitations in their access to resources, just in 1 year's time, our soup kitchen handed out 1.3 million meals. That is what we're dealing with here. So we have, and they gave out food in addition to the meals. We have people here who are living on the river in tents. We have tent cities. We have all kinds of difficulties, and I would love to try and mitigate the impact of this poverty on the women and children, because as we know, when the child is homeless, a child is going to have a harder time in school. They're not going to be able to, they may even be suffering from post-traumatic stress disorder. And that was a bill that we were able to address in public health a few years back to try and make sure that when a student is homeless, it might be recognized, the post-traumatic stress disorder symptoms would be recognized by the teaching staff. Which brings us to another issue that we look at.
Representative,
Yes.
I so appreciate your testimony and your knowledge. If you could just stick to the TANF part, that would be great. We have a lot of people before us that are waiting to testify.
I'm sorry, I get excited, so thank you for the reminder. But yes, I do hope that this will be a way for us to mitigate the problems with the children in school, because they won't be homeless. They'll have a stable home environment, and also will help women and children with respect to stable incomes, and also have access to job training, so that they can have a major change in their lives and be able to produce income for their families that's stable. So thank you so much for raising the bill and giving me a chance to talk to the committee. I really appreciate it.
Thank you, Representative. Representative Hughes.
Thank you, Madam Chair, and thank you, Representative Johnson. Can you just, for the committee, tell them what we are proposing to extend TANF support for?
The timeline. At the time, sorry. Yes. Okay, very good. It's 21 months right now with some exceptions. So there are a couple of exceptions to increase it to by 6 months for certain circumstances. And I have to thank the committee last year for the work that you did to eliminate the cap on the numbers of children, and also to include domestic violence as a part of the expansion of TANF. Thank you very much for that. But this is just for, this would expand it to 60 months, the 5 years, from 21 months to the 5 years that's allowed under federal law. And you look at some of the other states, they have provisions. They have you go back after 24 months and then go back for additional help if you need it, depending on what you're doing. So there could be provisions in here, because it's a block grant, to help these women with families to go ahead and be in a situation where they could maybe get some training, some certification, some way of making a living for the family, and get them that boot, so that they have the chance to live a decent life instead of constantly being recycled. We had for a while there, before we changed the law, we had homeless shelters recirculating the people all throughout the region. So they would be in the homeless shelter here for 60 days, and they'd have to go up to Danielson for 60 days, and then they'd have to go over to Norwich for 60 days, and they would circle around and around and around with their children. And there was a real problem in terms of how the children were getting the education. So it is a real serious issue.
And just real quick, how does this address the housing crisis?
Well, so I think that's an excellent question. Thank you. Because you need to have money to pay rent. And if you don't have any money to pay rent, then you're going to have to, you're going to end up in a homeless shelter. And so having that money to pay the rent will help with the stability, will help the person get the training and the education that they need to get into a stable position to earn the money to take care of the family. And this is something that we have, if you look at the Green Book, which was in effect in 1996, when the TANF program was first passed, almost 80% of women and children were off of the aid to families with dependent children by the time after 4 years, after 4-year time period. So I think that's probably why they extended it to 5 years or 60 months, because the data from all over the country was that it would be done in 4 years. But that, of course, also includes the fact that there were many more training opportunities under AFTC, many more opportunities to get support. And there also was a graduation. There was no cliff. So you didn't have a cliff from when you got to a certain income, you dropped off. There were subsidies that brought you along until you were at the full money that you needed to take care of the children. My cat's climbing on the table.
Okay, thank you, Madam Chair.
Thank you so much. Thank you.
Thank you, Representative. Representative Aurora.
Thank you, Madam Chair. I have two quick questions, and thank you, Representative Johnson. You have a wealth of knowledge on this issue, so I thought I'd ask you these questions. The first one is that right now we do have 2 6-month exception, and I just wanted you to confirm if I'm reading this right. And what you're suggesting is that we should be expanding it from 21 months to the original 60 months.
That's correct. I think that first of all, I've been talking to my former colleagues at Legal Services, and what they indicated, and you may hear this from them if they're signed up to testify today, is that the 6 months is never offered, and the people who who are told that they're no longer qualified because they've reached the 21-month limit, actually never or rarely ever get a chance to apply for that additional.
Got it. So what you're saying is that that 6 month is really for specific exceptions, not really used as much. So what you'd like is that what we should do is to go from 21 to 60 month. Now, the second question I have is that this was a block grant. This is funded by a block grant, because in the last 2 years, I have come across several situations where short-term funding is needed because somebody who's already working, but they run into a very tough patch and they need 6-month funding. And I go to the DOH and say, hey, do we have a program? They say, well, we really don't have a program. There's Section 8, which is really long-term, but it's very difficult to get. Really, we don't have a short-term program. And I'm like, I really need this person to get 3 months funding for their rent, and they're going to get back on their feet, maybe 6 months. That's what it is. And that program is just not, and I'm looking at this program, I'm saying, well, this is the temporary program. My question is that if we expand it to 60 months, does that, since the amount of funding is what the block grant gives, does that really mean that new folks who come in, so there's somebody who's on 60 months, but if a constituent who comes in who needs it for 4 months, they will not get temporary assistance now because the nature of the program changes from being a temporary assistance program for 1 month to 21 months to a long-term program. Does that not change the nature of the program? That's a kind of a worry which I have, because I do think there is need for temporary assistance. And do you have any thoughts on that?
Oh, thank you so much for that question. That's an excellent way to present the concerns that many people might have. So the temporary assistance for needy families, the 60-month rule would just be in a lifetime. So that's it. You don't get any more. You can go on and off for a period. You can go on for 24 months. and then find you're doing okay. But then you'll have an opportunity to go back on when you have a problem and get additional coverage under the TANF program, whereas right now you don't have that. Right now you have the 21 months. Most of the time people don't know that they can go back on for some exceptions. That also, as you know, will take time. If you're running into a situation where maybe you got laid off from your job and then you needed to get some help, fairly quickly, you'd have to go back there, but you could tell the landlord, I'm going to have X number of dollars for this period of time. And, you could make that kind of an arrangement with the landlord and try and get that extra money. But as a general rule, once people have that kind of an opportunity for up to the 60 months, they'll have more chances to get more stability in their employment situation. And that's what we're looking for here. Like I said, under the Aid to Families with Dependent Children, there were no limits, but 80% of all the people that were on that program over the period of time that program existed got off in 4 years and didn't have to go back at all because they had the support, they had the work background, they had the type of training that they needed to keep the family going and to be stably employed. And the other thing I'd like to add, just to follow up on your remarks, is the fact that we have a changing economy that's changing really quickly now. So this addition of time, going to 60 months, would really help the poorer families make that adjustment and maybe get the extra training they need to get that kind of a foot up so that they'd be able to support that family and create stability and make sure those children don't suffer that stress of the horrible thing of being homeless.
Yeah. No, thank you, Representative. I totally agree with you that there should be no one homeless in our beautiful state. It's just the nature of the temporary funding versus long-term funding, which I think our committee should definitely think about. So I appreciate your time and your input. Thank you to you, and thank you, Madam Chair.
Thank you so much. It would be still temporary. Thank you. Go ahead. I'm sorry.
That's okay. So Representative Rohrer, just for like an FYI, this program would still be considered temporary even at the 60 months. And this is also a program that has lapsed millions of dollars over the last 3 budget cycles. And why is that? Because people are not joining up. So if we think that we are going to run out of dollars or less people are going to be served, truthfully, I don't believe that's the case at all. But I understand where you're coming from and I appreciate your comment. Any further questions or comments? Seeing none, thank you so much, Representative Johnson, and thank you for your expertise. We do appreciate it.
Thank you so much, Madam Chair. I really appreciate the opportunity here, and I want to thank the committee as well. Have a great day.
Thank you. Have a great day. We're going to move back down to the public part of the testimony, and just to remind everybody, you have 3 minutes to testify, and then our good clerk, Heather, will come on screen, and she'll just have to tell you your 3 minutes are up. So with that, up next is Isabel Alvarez Diaz. Isabel?
Senator Moore, Representative Abercrombie, and distinguished members of the Human Services Committee. My name is Isabel Alvarez Diaz, and I am a first-year graduate student enrolled in the dual degree Social Work and Women's Studies MSW and MA program at Southern Connecticut State University. First, I'd like to thank you for the opportunity to present a testimony in support of SB number 197. SB 197 on temporary family assistance proposes an extension on the time limit from 21 months to 60 months. Extending the duration of temporary family assistance will be beneficial during times of stress, a change of circumstances, or a global pandemic. A total of more than 20,000 people had enrolled in temporary family assistance in Connecticut as of January 2020. Although a decrease of more than 50% since 2012, it still is a significant number of people who need and are eligible for assistance. Cash assistance provides the opportunity for families eligible to 1, meet basic family needs, 2, build stability during crises, 3, promote racial equity, and 4, assist families in helping their children succeed. With this in mind, families are cut off from receiving these opportunities due to factors such as the time limit. Time limits disproportionately affect families, especially families of color who are cut off and report facing more hardships due to financial instability. Though families may apply for a 6-month extension, there's no guarantee that they will receive it. Connecticut is one of the few states that has enacted a shorter time limit in comparison to the federal maximum limit of 60 months. 21 months is not sufficient enough for families to build, foster, and maintain stability, especially for those who deal with inequities. Inequities have loomed over Connecticut for years, highlighting disparities in healthcare, education, housing, economic stability, to name a few. The pandemic has worsened and amplified these disparities across Connecticut residents. For example, 512,000 residents have applied for unemployment benefits since the start of the pandemic in cities such as Bridgeport with 22,444, Hartford with 19,911, and New Haven with 16,230. Families may also experience time periods of being uninsured, leaving residents unable to access adequate health for not only themselves, but for their children as well. In one study, 15% of low-income adults report not having been able to afford prescriptions. Increasing the time limit of temporary family assistance may assist those in experiencing these hardships a chance to afford health care, to support their children's education, to promote racial equity, to meet basic needs, and to build stability. Though I'm in support of SB 197, I urge for the consideration of reforms that address the jarring inequities and move towards improvements to prevent and minimize disparities in order for all Connecticut residents the right to live an adequate life. Thank you.
Great job, Isabel. Thank you so much, and we wish you the best of luck in your education. Any questions or comments? Seeing none, thank you so much for taking the time to testify today, and have a great day. We're going to move back to the elected officials, and I see our Minority Leader of the Senate, Senator Kelly. Good morning, sir. Thank you for being here.
Good morning. That was certainly a tough act to follow. She did a fantastic job. I was impressed as I listened. So very good job. Thank you very much, Representative Abercrombie, also Senator Moore, Senator Berthel, and Representative Case, as well as all the members of the Human Services Committee. I do miss being with you. I enjoyed my years as a member of the committee. And I do thank you not only for your service on this very important committee, but also for reasons Senate Bill 195, an act increasing the minimum amount of assets that may be retained by a community spouse. I'm not going to read the written testimony. Really what I want to say is that when I came to the General Assembly back in 2010 with the Malloy administration, at the time, coming off the heels of Governor Ralph, community spouses got a maximum community spouse protected amount. And over the years, that has been reduced to 50%. And here we are now with a budget surplus, a rainy day fund of record proportion. And I think it's time to give that senior community spouse the opportunity to get the maximum amount. Generally speaking, in the neck of the woods that I live in, in Stratford, when I see individuals in this situation, and what we're talking about is a husband and wife who are actually could be even, what you have is a situation where, you have a home of maybe $250,000 a Cape, and then about $100,000 bank account. And when the first spouse gets sick, there's a program in Medicaid known as a spousal impoverishment, which is a protection for the community spouse that stays at home so that they can cover the bills of the aging institutionalized spouse. Right now, we'd split that $100,000 in half. The institutionalized spouse would have to spend that down to $1,600, and the community spouse would only have $50,000. And that would be to pay taxes, to pay upkeep, to maintain the house. And the assumption by DSS is that that institutionalized spouse spends that $50,000 on, I'm going to say, nursing home costs. When in reality, what happens is the spouse buy a reliable transportation, which nowadays is easily $30,000 and a funeral contract. And so it doesn't go to deferring costs of Medicaid. Medicaid still picks up at the same time. What it actually does is it reduces the community spouse's asset and puts that person in a greater likelihood of needing nursing home care sooner. In other words, it accelerates a Medicaid appropriation on behalf of the community spouse. So that's why I think this is just it's a common sense. I think it's also fiscally responsible, but it's what people want. When I ever ask people, where do you want to be? Do you want to age in place or do you want to be in a nursing home? 95% of people say they want to stay at home. This is a bill that enables the community spouse to stay at home. And that's why I think this is important. And I would urge approval. So thank you again, Representative Abercrombie, and thank you for your service to the state of Connecticut. So thank you.
Thank you, Senator. It's always been a pleasure working with you on these issues. And I always appreciate your expertise. So thank you so much for taking the time to testify. And hopefully this will be the year that we'll get it done. I think you and I have worked on this bill for at least 3 or 4 sessions. So thank you for that. Representative Hughes?
Thank you, Madam Chair, and thank you, Senator, for proposing this bill. Again, can you just tell for the committee, what is the average cost of applying for Medicaid, for applying for that application in our neck of the woods, as you say?
You mean to a private practitioner or for the cost of care?
No, for the private practitioner, which is not factored in now to what you're leaving for the assets for the spouse.
Yeah, I mean, well, I guess there's 2 levels. There's going to be what I'm going to call the Medicare for You, which are just, an organization that would be a conduit between the family and the Medicaid agency, which is BSS. And they run somewhere in the neighborhood of $5,000 to about $7,000 or $8,000. If you hire an attorney, you're running anywhere from $10,000 to $20,000. Depending upon the volume and the work. Obviously, I'm an attorney. I would strongly recommend an attorney because what they're going to do is evaluate, in this particular instance, advocate for the family to make sure that it's not only processed timely, but that they set things up to make sure that they not only get the quality care for the institutionalized spouse, but also the necessary protections to allow the community spouse to age in place.
Right. Thank you for that. I think that's incredibly important as we consider raising the limit, that it's $5,000 to $10,000 to $20,000 just for the Medicaid application process. And, so we need, you're right, we need, transportation, we need to be able to pay, property taxes, but we also need some assets to spend towards that. I think people think it's automatic or the state pays for it. That's not at all the case. For timely application of the Medicaid application. Yep, thank you.
Any further questions or comments? Seeing none, thank you so much, Senator, and have a great day.
Thank you. You do.
Thank you. Up next, number 10, Tracy Wodach. Hi, Trace.
Good afternoon, Representative Abercrombie, Senator Moore, and distinguished members of the Human Services Committee. My name is Tracy Wodach, President and CEO of the Connecticut Association for Healthcare at Home. I am also an RN with nearly 40 years experience. The association is the united voice for our licensed home health and hospice agencies, as well as several homemaker companion agencies. I'm testifying before you today to ask for additional funding in the state budget to stabilize and invest in the future of care at home in our ever-growing aging state. Our providers have a unique role in healthcare as they do not work in institutions. They go into people's homes alone, not knowing what is behind the closed doors. They face multiple risks regularly, including drugs, guns, abuse, neglect, and yes, COVID. Yet in 2017, the add-on rates to help mitigate some of these risks were eliminated. And in 2016, the home health behavioral health medication administration rate was cut by 15%. The recent ARPA funding is genuinely welcomed, yet doesn't begin to make up for 15 years of flat funding, combined with the COVID costs and inflationary impact. During the pandemic, our providers have lost up to 20% of their staff to hospital and nursing home providers who received added funding and were able to offer far more competitive wages. Regarding complex care services for the medically fragile living in the community, last year's budget and the ARPA funding provided a 31.7% increase for pediatric complex care, much needed. But adult complex care, same nurses, but 19 and older, only received a 4.5% increase. This created a 27.2% gap in this vital level of care. The overall result of these cuts, lack of adequate funding and disparities, a workforce crisis, fewer Medicaid cases served in the community, inability to hire and retain staff, and higher costs of care for the state, a vicious, unnecessary cycle. Additionally, with the growing needs of the community, home health social workers serve a key role as they assist patients with community resources, including Medicaid and waiver services, and support the psychosocial emotional needs of those with mental health and serious illnesses. Yet there is no Medicaid home health social work rate. Here are our asks: consistent annual provider rate increases, a 10.5% increase in behavioral health med-admin rate, and reinstate the add-on rates. Add the 27.2% increase to adult complex care to align with the new pediatric rate, and create a Medicaid home health social work rate. Lastly, while we support the concept of House Bill 5227 to create a community ombudsman program, we urge the legislature to first invest in and stabilize the home care provider services before allocating dollars to create a new program. Thank you very much.
Thank you, Tracy, and thank you for all you do. Questions or comments, colleagues? Seeing none, thank you, Tracy. Have a great day.
Thank you.
Up next, Michael Werner. Michael?
Good morning. Yes, hello. Senator Moore, Representative Abercrombie, Senator Berthel, Representative Case, and other distinguished members of the Human Services Committee. My name is Michael Werner. I am the lead aging policy analyst for the Commission on Women, Children, Seniors, Equity, and Opportunity. Here today to testify on what I believe to be one of the most critical bills before you, and that's HB 5227, an act establishing a community ombudsman program for home care. Smartly, this bill builds upon the established success of the existing Office of the Long-Term Care Ombudsman, who has had boots on the ground throughout the pandemic and many years prior. This bill properly addresses the autonomy and independence requirements necessary for the program by expanding the current structure and leveraging its institutional knowledge and proven leadership, which will allow for the office to get set up and get to work. Since 2003, the state has been working through its rebalancing efforts to deinstitutionalize and promote Connecticut's residents to age well in place under the least restrictive means in the setting of their choice. The Community Ombudsman Program would be a sound reinvestment into quality assurance to meet the booming demand for home-based and homemaker companion services. Multiple governmental authorities have acknowledged the need and affirmed support for the concept of an expanded ombudsman role in Connecticut, including the Community Ombudsman Work Group, the Long-Term Care Planning Committee from OPM, the Long-Term Care Advisory Council, and the Senior Fraud Task Force, which recently submitted its report to the Aging and Human Services Committees, echoing the call in its primary recommendations to protect older adults from fraud and financial exploitation through an expanded ombudsman program. One of the most critical aspects of the program is in its non-mandated reporter designation. This allows for more candid conversations between potential complainants and an expert liaison authority who's unbiased and there to protect rights and help make informed decisions. Home-based LTSS recipients are considered consumer employers, and this population in particular would benefit by having access to this informed consent assistance providing service. Only about 1 in 23 older adults ever report when they've been a victim of a crime. There is shame, fear of conservatorship, non-cooperation in terms of wanting to report on loved ones or caretakers who may have stolen from them, and the state's own limited resources when it comes to investigations and prosecutions. This new role could be key and preventing the harms downstream that come when it's too late to fix a problem upstream. Having an ombudsman available to all LTSS recipients, regardless of settings, will ensure a safety net for a rapidly growing population of taxpayers who continue to contribute to our local municipalities and who, as a public policy, serve the state well by aging at home in our communities. Thank you for this opportunity to testify before you today.
Thank you, Michael. We really do appreciate. Any questions or comments? Seeing none, thank you so much for your testimony. We appreciate it. Have a great day.
And thank you to the committee. Thank you.
Moving on to number 11, Robin Anderson. Robin. Okay, we will move on to number 12, Kevin Brophy. Kevin.
Good morning. My name is Kevin Brophy. I'm the elder law managing attorney for Connecticut Legal Services, and I'm testifying in support of Bill number 196, an act prohibiting discharge from nursing homes and RCHs, residential care homes, to temporary or unstable housing. And I'm submitting my testimony on behalf of all three legal aid programs. The current discharge statute, 19A 535 for nursing homes and 19A 535A for residential care homes, does not prohibit discharging residents to homeless shelters or to temporary or unstable housing situation for a short period of time. I had a client who was in a nursing home for many months. He was on Husky D, and he lost his Husky D because he turned 65, and he was now eligible for Medicare. So that was one of the criteria. You can't be on Medicare and get Husky D. He had had 3 strokes. He could not walk. He was in a wheelchair, and he received a discharge notice to send him to a homeless shelter in in Meriden. He contacted us at Legal Aid. We were able to stop the discharge because the notice was defective. And then we were able to find a pro bono attorney who helped him with the Husky C long-term care application and got him on Medicaid. There was an article about my client in the newspaper, and I attached it to my testimony. In response to articles like that and stories about clients like mine, Governor Lamont issued an executive order which suspended discharges to homeless shelters from nursing homes and residential care homes. However, that order has expired. So what SB 196 would do, it would amend 19A 535 and 19A 535A and prohibit discharges to homeless shelters and to temporary or unstable housing situations, such as hotels, motels, or other similar lodging for short periods of time. Nursing home and residential care homes must have an appropriate discharge plan in place and adequate safeguards in place in the community before discharging a resident. Sending a vulnerable person in poor health to a homeless shelter or other unstable housing is never appropriate, and it's not a safe discharge. They either will end up in the hospital, back in the nursing home, or worse, dying. I also attached an article from the New York Times that was during the pandemic, and the title of it is, "They Just Dumped Him Like Trash, Nursing Evict Vulnerable Residents." I have a couple of comments about DSS's testimony in regard to this. One of the things they say in their written testimony in regard to SB 196 that they do not support says DSS hearing unit handled approximately 10 nursing facility involuntary discharge cases that ultimately resulted in relocation to temporary or unstable housing. And that was, as a result of COVID-19, that was that was suspended for a short period of time.
Excuse me, your 3 minutes are over. Can you please summarize?
Yep, just take me a minute. Thank you. What I wanted to comment on was that at Legal Aid, we get a lot of calls from clients who are told by nursing homes that they got to leave immediately. They have no idea that they have a right to a notice and that the only person that can order them to move is a fair hearing officer. So it's greater than just the 10 that they're referencing that they've seen. That's number one. My second comment about her testimony, I commend the legislature and DSS for programs like Money Follows the Person in the new chest program. But what bothers me, it kind of absolves the nursing home from any responsibility for trying to support people when they're doing a discharge plan to land on their feet so they don't wind up in a nursing home. And under this, and part of the problem, by the way, is the fact that they don't have enough staff. And the legislature last year kind of addressed that. They increased the number of social workers. If there's more than 60 residents, for every 60 residents, there has to be one social worker. And what we've seen at Legal Aid in the past, they weren't doing appropriate discharge plans because they didn't have enough support, the social workers. So again, I please encourage you to support Raise Bill 196. I would just like to end in that article that I attached about my client. Yes?
Kevin, we so appreciate your testimony. We get what you're saying, but I really have to adhere to the 3 minutes because we have a lot of people that want to testify. But I do understand what you're saying. That's why this bill is before us. And I so appreciate your testimony. Representative Hughes.
Thank you, Madam Chair, and thank you, Kevin, for your experience in this pandemic and beyond. Let me ask you, would Bill 196 impact if we had a long-term care community ombudsman in terms of the both legal and legal rights of community-based folks in terms of getting support, even discharge support if they don't have it? Do you think that would fall under establishing a community ombudsman's office?
I haven't carefully looked at that, but my instinct would say yes, absolutely. The more supports that are available to residents in nursing homes and to residents in residential care homes and the social workers that are working with them, the better. So yes.
And the oversight, right?
Correct, absolutely.
That's my sense, but I wasn't sure, and that these two work very, very much hand in hand. We can't just stop the involuntary discharge to unsafe things without another service sort of supporting people and getting stable housing and supports, because these are, like you said, most vulnerable, sickest folks that don't have the autonomy to get the type of help they need.
Yes, absolutely.
Thank you.
Thank you, Representative Hughes. Seeing no other questions. Thank you, Kevin, for your testimony.
Thank you very much.
Have a great day.
Thank you.
Up next is number 13, Kathy Flaherty. Hi, Kath.
Hi, Representative Abercrombie, Senator Moore, members of the Human Services Committee. I will help you gain some time back. I'm here to testify on two bills in support of SB 196. I basically co-sign everything Kevin Brophy said. CLRP, of which I'm the executive director. My name's Kathy Flaherty. I think I forgot to say that. We represent people who are eligible for mental health services from DEMIS, which means we are representing clients who unfortunately sometimes still end up in nursing homes as younger people with disabilities. So I co-sign the comments of my elder law legal services colleagues. Also in strong support of HB 5232. Way back in the days before the pandemic, Representative Abercrombie convened a working group to deal with Connecticut statutes regarding service animals for people with disabilities. This is that bill again. It made it through one chamber last year, but wasn't brought up for a vote in the other. I really encourage the committee to advance the bill so it can get all the way through this year.
Thank you, Kath, and thank you for your work on the service animal bill. I so appreciate it. And yes, hopefully we'll be able to get it out of the Senate this year and we'll be on the same page. So any questions for Kathy Flaherty? Seeing none, thanks, Kath. Have a great day.
You too.
Up next, number 14, Jocelyn Atunes. Jocelyn.
Good morning, Senator Moore, Representative Abercrombie, and distinguished members of the Human Services Committee. My name is Jocelyn Antunes, and I'm testifying on behalf of New Reach in New Haven. As an agency, we aim to make homelessness rare, brief, and non-recurring. This is done through providing crisis services, stabilization programs, and both supportive and affordable housing programs. Thank you for the opportunity to provide testimony in support of HB 5225, which would prohibit the practice of state agencies clawing back surplus funds from nonprofits at the end of the fiscal year, allowing nonprofits to retain savings and reinvest them into the provisions of services. Despite the legislature already having passed 3 laws to eliminate the practice of clawbacks, state contracting policies continue to mandate that nonprofit savings must be returned to the state. Nonprofits have been at the front line of providing services throughout the COVID-19 pandemic. Unlike other businesses, New Reach was not able to shut down during the pandemic, but needed to continue to provide essential services to those experiencing homelessness. New Reach took the historical need of the community while experiencing a burden of unexpected expenses and historically low vacancy rate. Given the opportunity to retain funds, New Reach would have the flexibility to invest in the staff by promoting a living wage, offset the continuous increase in healthcare coverage, and the ever more present need for technology. Through our current funding, New Reach does not secure enough funding to cover the actual costs of daily operation, so having the flexibility to spend funds strategically would be the best use. For 5 years now, we've come before this committee to stress the importance of flexibility in funding for nonprofits. But this year is exceptional in that COVID-19 has demonstrated exactly how illogical it is that nonprofits are forced to pay back money to the state in the midst of a deadly pandemic. Although during my time at New Reach, we have not been required to pay back money, these are unprecedented times and there's a bigger need to be flexible now more than ever. Finding ways to spend down items under certain line items cannot be the answer. Despite support from the committee, the legislature and nonprofit community since 2017, the innovation program has yet to be implemented. This year has highlighted the sense of urgency and the need to start the end of the practice of clawing back surplus funding. I ask that you approve this bill in order to give nonprofits the flexible financing they need to address the needs of those experiencing homelessness by ensuring that homelessness becomes rare, brief, and non-recurring in our great state of Connecticut. Thank you so much for your time.
Jocelyn, thank you for your testimony. We so appreciate it. Any questions from committee members?
Thank you.
Seeing none, thank you, Jocelyn. Have a great day.
You as well.
So now we're going to move on to number 15, Stephen Monroe, but I'm also going to turn over the chairmanship to Representative Leeper. I will be going on appropriations, but I'll still be listening to both. So thank you very much. Stephen, welcome. And Representative Leeper, thank you for helping with this.
Thank you, Chairwoman.
Senator Moore, Representative Abercrombie, and members of the Joint Committee on Human Services. I appreciate the opportunity to address you in support of Senate Bill 197, an act concerning temporary family assistance. My name is Stephen Monroe Tomczak. I live in Wallingford and teach social welfare policy as a member of the faculty at Southern Connecticut State University Department of Social Work. Today, I'm representing the Social Welfare Action Alliance Connecticut chapter, which is a group of professional social workers, allies, and community activists who are working in partnership with those communities identified as being most negatively impacted by social inequities. The inequity this legislation aims to correct, the excessively short duration of the state's time limit for cash public assistance under the Federal Temporary Assistance to Needy Families Program, is an injustice long in need of correction, both on moral and practical grounds. Connecticut is second only to Arizona in having the shortest time limit on public aid for needy families and is the shortest in the New England region. Time limits not only negatively impact the well-being of families with children, as research demonstrates, they interfere with the stated program goals of facilitating employment, particularly among those that face significant cumulative disadvantages. Many people leave TFA after a few months, but many others face substantial barriers to employment that cannot be surmounted in 21 months. Research shows that reliable and stable support for a longer term, 6 years or more, results in greater self-sufficiency and long-term benefit. Unfortunately, our state's artificially low TFA time limit discourages people from applying for TFA as data show that fewer than 22 of 100 families in poverty in Connecticut receive basic assistance. As someone who teaches about and conducts research on programs and policies that meet human need, I'm particularly concerned with these negative impacts on families with children with, of restrictive time limits. As research clearly shows, they're unnecessary, ineffective, and harmful. And extending them to the federal limit of 60 months, as SB 197 proposes to do, will not likely be particularly costly for the state. As research shows nationally, most participants on TANF are on TANF for 1 year or less, and only a small percentage are on TANF for more than 3 years. It's important to note, however, that extending time limits for TFA, while an important step in alleviating this deprivation faced by families on public assistance, should be followed by more comprehensive structural reforms that ensure adequate economic security for all in the state. Ultimately, at the state level, expanding the state EITC, the child care tax credit, and other necessary supports for economically disadvantaged children would be families with children would be advisable. Additionally, working at the federal level to repeal the harsh 1996 welfare reform law so that we can eliminate time limits altogether is also needed. From a longer term perspective, we should consider shifting towards more universal programs that guarantee employment and adequate wages, universal income supports, among other economic human rights.
Excuse me, please, sir. The 3 minutes are over, and please summarize. Thank you.
Very good. I would close by asking you to support Senate Bill 197 so that families with children do not have to face these extreme time limits and can improve their lives. While we must go further to address the root causes of poverty and economic deprivation, this legislation constitutes an important first step in the direction of social and economic justice. Thank you very much.
Thank you, Stephen, for your testimony. I see you have a question from Representative Hughes.
Thank you, Madam Chair, and thank you, Stephen, for that very comprehensive, broad view. I totally support everything you say. How does this bill address Connecticut's affordable housing crisis in your view, in your experience?
Well, I think certainly the degree to which families with children are able to stay on cash assistance for a longer period, this would alleviate pressures, other pressures that might, impact their ability to obtain housing. So I think that, the expanding various areas of the social safety net, I think, is important. And they are interactive with one another to some degree. So the degree to which you provide families with cash assistance for a longer period, this may also help the housing crisis.
That's my sense, but I didn't know. And also in terms of children, going to daycare or to schools, where does this fall in that realm in terms of the timeline?
Well, again, I think that the degree to which families are provided with cash assistance for a longer time period, which is what 197 does, alleviates other pressures in family budgets, including potentially the expense of childcare and other supports. It also allows them to retain other social supports for childcare that are related to the TANF program. So I think that those are the ways in which it interacts with that policy area as well.
Great. And just one final thing is when you apply for TANF, you can see what your eligibility is for some of those other child care subsidies that you were talking about, correct?
That is my understanding.
Right. So it's a really important portal to some of those safety net programs that otherwise people may be unaware of, not know that they're eligible for, and that, really helps create that base foundation of stability. So thank you so much for your testimony.
And thank you for your questions.
Thank you, Representative Hughes. Does anyone else have a question for Stephen? All right, I don't see any other questions. Thank you, Stephen, for your testimony. Next is number 16, Alma Hernandez.
Good afternoon. Can you hear me? Can you hear me? Okay.
Yeah.
Thank you for allowing me to testify today. My name is Alma Hernandez. I live in Ellington. I am submitting testimony in support of Bill number 5227, which is an act establishing the Community Ombudsman Program for Home Care. My dad, who is 88 years old and lives in South Windsor, has vascular dementia along with other medical conditions. Because of the dementia, he requires 24-hour home care. I am extremely grateful to the state of Connecticut for the services that he is getting. He has been receiving home care for approximately 6 years. I have extensive experience with the services of home care providers. Throughout the years, there have been challenging issues regarding the quality of care that my dad has received. Most concerning was an incident that occurred on the morning of June 12, 2019. My dad's caregiver died of a heroin fentanyl drug overdose while in my father's home. Many bags of what appeared to be heroin and crack cocaine, in addition to drug paraphernalia, were found in my dad's home. If you're wondering how this happened, I just want to make an aside note that the state of Connecticut does not require these workers be tested for the use of illegal substances prior to or during employment. And I'm currently working with Senator Anwar to hopefully address this specific concern. But because there wasn't an ombudsman program available for me to contact, my only choices were to contact the Department of Consumer Protection, which is the department that currently is in charge of licensing home care agencies. I contacted them. They conducted an investigation many months later, and basically, ultimately, they said that they couldn't do anything because the home care agency had not violated any policies. On my own, I also contacted Elderly Protective Services. They informed me they had no jurisdiction over home care agencies. I believe that the committee's support and passing of this bill will give families a resource to be able to bring matters such as mine to the attention of an ombudsman that not only will be able to provide support, but hopefully will make recommendations to the state legislature about future legislation that will ultimately protect individuals receiving home care services. Thank you for the opportunity to offer this testimony in support of this bill.
Thank you so much, Alma. I'm so sorry to hear about what you and your family endured. Does anyone have any questions for Alma? I don't see any. Thank you so much for giving your testimony today.
You're welcome. Have a great day.
You too. Next, number 17, Diane Stone.
Hi, Diane Stone. I'm here representing the ADA Coalition of Connecticut today. And I wanted to join with my friend Kathy Flaherty and Bill DeMeo, who you may hear from later on today, in strong support of raised Bill 5232, an act concerning service animals. This is not a new bill to you. You saw it previously. And it's a good example of smart public policy done smartly, because in 2019, there were a host of bills presented to deal with the real problems that exist with support animals in Connecticut. The problem was the information was all over the place, and there's a clear misunderstanding about what support animals are and what laws govern them. So this bill really just seeks to align Connecticut statutes with federal statutes so that we have this baseline of understanding. We can start doing some of the training and education. Some of the problems, things like dogs in restaurants, covered by the ADA, emotional support animals in apartments, that's covered by the Fair Housing Act, or animals in airports and on planes, and that's covered by the Air Carrier Access Act. We've all heard the stories, and really this just starts to align our statutes with the federal law and to create that platform for training and education. I also wanted to use a few minutes, a quick word about Bill 5231, data collection to prevent malnutrition. And this is from my perspective, having a 23-and-a-half-year career working in a senior center. We're the last mile of the senior nutrition program. Appropriate you're bringing it up this year. This is the 50th anniversary of the senior nutrition program federally. We've always saw the impact of the elderly nutrition program, never more so than during the pandemic. Probably the most meaningful time that I spent during the pandemic was standing outside every week, handing out meals to older adults who were staying home and staying safe. It's an incredibly important program. I do support using better data to improve the program. And I think that's the underlying intent of the bill, is to become data-driven. Data collection takes place. Let's do it better, more meaningfully, and use that data. But I want to make sure that we're all sure that we're not just looking for better ways to slice a pie and to make it more equitable or more even. We need a bigger pie. And I think we need to recognize that. We're Connecticut. No older adult should ever be waiting to get a meal. So hopefully this information and this process that you're on and your decision-making around funding can be supported by this data so that we make sure that the senior nutrition program reaches everybody who needs it. Thank you very much.
Thank you so much for your testimony, Diane. Does anyone have any questions for Diane? I don't see any. Thank you very much. Next, we have number 18, Marissa Mangone, and please forgive me if I mispronounced it.
No, all set. Thank you so much. Greetings, Representative Abercrombie, Senator Moore, Senator Berthel, Representative Case, and members of the Human Services Committee. My name is Marissa Mangone, and I am the Chief Business Development Officer for Clifford Beers and its network of affiliate partners. Every year, we deliver a broad array of mental health and community support services to over 5,000 at-risk children and families in the greater New Haven and greater Norwalk regions. Every day, we tackle some of the most challenging and complex problems facing Connecticut's children and families, and we proudly advocate for our community's most vulnerable populations. Thank you for the opportunity to provide testimony in support of House Bill 5225, which would prohibit the practice of state agencies clawing back surplus funds from nonprofits at the end of the fiscal year, allowing nonprofits to retain savings and reinvest them into the provision of services. It is important to remember that funding from state agencies only covers a portion of the cost of delivering high-quality mental health services. To survive, we must rely on alternative funding streams, such as private donations, to help offset operating losses associated with the delivery of these critical services, which, as you can imagine, has been increasingly challenging over the last 2 years. Furthermore, state funding has not kept up with inflation. Over the last 10 years, inflation has increased our operating costs by over 25%. During this period, we only received a 4% increase in state funding. In this context, clawbacks simply make no sense. Further, the COVID-19 pandemic has significantly impacted our operating capacity. We are experiencing an unprecedented clinical workforce shortage that directly impacts our ability to support the increased need for our services. Market demand for clinicians continues to exceed supply, which makes retention of these professionals difficult. Salaries offered for for-profit sectors often far exceed those offered by agencies like Clifford Beers. House Bill 5225 is critical to the viability of our organization and all nonprofits. By retaining and reinvesting savings, we can preserve and enhance the delivery of mission-critical services, build the infrastructure needed to improve operating efficiencies, provide more competitive salaries to improve employee retention, and most importantly, improve client care and client outcomes. DCF-funded programs are the backbone of the child mental health system in our state, and while a balanced state budget may make it appear that DCF is funding us appropriately, the reality is that it is not. It is also important to understand that there really are no unspent funds to be returned via clawback. In reality, unspent funds only exist because a state only allows an inadequate percentage of their funding to be used for essential overhead expenses. In other words, if state funding allowed us to cover reasonable overhead expenses, there would be no such thing as unspent funds. We are dedicated to our mission to help the children and families in the state, but facing clawback creates uncertainty and only adds to an already incredibly stressed system. Thank you so much for this opportunity to speak to you today.
Thank you so much for your testimony, Marissa. Does anyone have any questions? All right, I don't see any. Thank you again for your testimony. Next up is number 19, Coco Selman.
Hello there. Thank you very much for having me today. Thank you, chairs, vice chairs, ranking members, and distinguished members of the Human Services Committee. My name is Coco Selman. I am the founder of Alume Home Care, which recently merged with All Point Home Care, a Connecticut home health provider. I am now the co-owner of All Point Home Care. I'm also the mother of Amelia, a 20-year-old young woman who requires around-the-clock in-home nursing care due to her complex medical needs. Today, I'd like to address two bills. Number one, HB 5040, an act concerning the governor's budget, and HB 5227, an act establishing the Community Ombudsman Program for Home Health. All Point Home Care is a Connecticut licensed Medicare accredited home health agency providing services to more than 80 towns in our great state. Our patients are funded 90% by Medicaid. We care for the state's most vulnerable at home. Our dependence on you today is critical. We specialize in in-home complex nursing care of technology-dependent, medically fragile children and adults with tracheostomies, ventilators, G and J feeding tubes, and other intensive at-home medical interventions. So I submitted written testimony on 4 requests today. I'd like to focus my testimony here today on just one of those requests, specifically that around adult complex care in-home nursing and the need to have the Medicaid rate to be increased to the same level as pediatric complex care rates. The temporary ARPA funds provided a very needed increase of 30% for our pediatric complex care nursing, but it only serves those through age 18, and it does not address the needs of adults ages 19 and older. Both of these rates are temporary in place through ARPA and need to be made permanent in the Medicaid budget as they ensure the ability for us to continue to provide these very important services to our state's most vulnerable at home. Last year, I urged through testimony the increase of these rates, and we thank you for those that came through the ARPA. My daughter, Amelia, 20 years old, who advocated with me on the steps of the Capitol last summer, people like her and her age and older are left out because of her age. I have to believe this was an oversight and was unintentional. A bit more for those here that don't know about complex nursing care. Connecticut is facing a crisis. There are more than 400 families whose medically fragile loved ones live at home. More than 30%, 35% are adults, in fact, and they're living home with continuous skilled nursing services rather than much more expensive hospital intensive care units where they would otherwise have to be. So huge difference in cost, about $1,000 a day to live safely at home with their families through home health versus through a intensive unit, which is around $8,000 or $9,000 per day. So just a decade ago, institutional care.
Excuse me.
Yes.
I'm sorry that your 3 minutes are over. Please summarize.
Yes.
Thank you.
Yeah, so in summary, I request that you increase the rates of adult complex care to be the same as with our pediatric rates, and to make those rates that came to us through ARPA, make those permanent. Thank you for the opportunity to provide testimony, and please feel free to contact me with any questions. I'm incredibly grateful for your service.
Coco, thank you so much for your testimony. Does anyone have any questions? I don't see any. Thank you so much. Have a great day.
Thank you.
Next up is number 20, Patricia Gibney.
Sorry about that. Okay. Hi, how are you? Can you see me?
Yes.
Okay. So good morning, Senator Moore, Representative Abercrombie, Senator Berthel, Representative Case, and members of the Human Service Committee. My name is Tricia Gibney, and I'm the CEO of the ARC of Southington. We provide services to people with intellectual disabilities in Southington, Wallingford, Cheshire, and Hampden areas. Thank you for the opportunity to provide testimony to support the HB 5225, which will prohibit the practice of state agencies clawing back surplus funds for nonprofits at the end of the fiscal year, allowing nonprofits to retain savings and reinvest them into the provisions of their services. Despite the legislative already having passed 3 laws to eliminate the practice of clawbacks, state contracting policies continue to mandate the nonprofit savings must return to the state. Some examples of where my agency would be able to benefit to retain any of the previous year's unused fundings would be staffing shortages have created the need for large amounts of overtime expenses, recruitment expenses such as advertising and training, the ongoing need of PPE and COVID-related expenses. Vacancies within our agency not only are a huge expense, but also very difficult to fill due to the staffing crisis. The cost of living has increased and is expected to only rise with the current situation in Ukraine. Having funds available will eliminate the need for a line of credit to keep our agency current in its obligations. For 5 years now, we have become before this committee to stress the importance of flexibility in funding for nonprofits. But this year is exceptional in that COVID-19 has demonstrated exactly how ethical it is that nonprofits were forced to pay back to the state in the midst of in a deadly pandemic. Being able to retain our surplus would keep the agency current in its obligation and limit the need to pay interest when we borrow on our line of credit. This year has heightened the sense of urgency and the need for the state to end practice of clawing back surplus funds. Thank you very much.
Thank you so much, Patricia, for your testimony. Does anyone have any questions? I don't see any. Thank you and have a great day.
Thank you. You too.
Sorry, I just muted myself. Next is number 21, Susan Brousseau.
Good afternoon, distinguished members of the Human Services Committee. My name is Susan Brousseau, and I'm the Chief Financial Officer of Edelbrook Community Services. I'm a CPA with 35 years experience with both for-profit and nonprofit businesses. At Edelbrook, we provide homes in the community to young adults who have autism spectrum disorder and IDD, as well as group homes for young women who have experienced significant trauma. Many of the individuals we serve are finally able to leave a hospital setting when they're placed with Edelbrook. This level of services is our area of expertise and our mission. Thank you for the opportunity to provide testimony in support of HB 5225, which would prohibit the practice of state agencies clawing back surplus funds from community nonprofits at the end of the fiscal year. Despite the legislature already having passed laws to eliminate the practice of clawbacks, here I am, I'm back, because state contracting policies continue to mandate that net income earned by community nonprofits must be returned to the state. Clawbacks have caused community nonprofits to be in a lose-lose situation financially for many years. We give money back to the state if we have a surplus, but if we lose money in a year, that's our problem. It's on us. I have testified before that the clawback from nonprofits is extremely unfair, as no for-profit state vendor would ever be expected to return their net income from a straight contract back to the state. No business can run successfully in the long term without a minimum level of a cash surplus, whether for-profit or nonprofit. After many years of clawbacks, community nonprofits have been left without cash reserves for not only unexpected expenses, hello COVID, okay, but for program growth. Here is why a retained surplus is so necessary for any business, including community nonprofits. Any business, including us, should have at least 3 months in cash to be prepared for an emergency. Lack of cash requires us to pay higher interest rates on debt when we borrow, because we don't look like we're financially stable. Lack of cash requires us to operate in a panic mode, addressing the latest financial crisis rather than considering long-term careful planning. And we must have cash reserves to be able to pay for immediate expense increases that are beyond our control, such as the current year inflation and the annual increases to healthcare costs, which I dread, but I deal with every spring when we renew. The clawbacks have unintended consequences. Community nonprofits has a disincentive to merge. Why take on additional risk of another agency's cash shortage? In other words, rather than combining and being super efficient and giving DDS and DCF fewer agencies, we're hesitant to take on somebody else's problems because we're short of cash for our own programs. Community nonprofits have a disincentive to add additional homes to existing programs. Why risk losing even any more money by adding an additional home? And this is not a growth industry. There's not new providers that are coming on board. Community nonprofits are incentivized to spend down the funds in the fiscal year rather than planning for use in future years. So let us keep it and we'll plan with it. Community nonprofits must ask DDS and DCF staff for permission to purchase capital items like vehicles, which creates additional work for the state employees who currently have their own staffing issues. I work with great people at DDS and DCF. They're fantastic. They have some of the same staffing issues that I do.
Excuse me, your 3 minutes are over. Please summarize.
And State employees have become involved in more of the detailed spending decisions of community nonprofits, when we're always asking, can I do this? Can I do that? Rather than letting us keep the surplus. Thank you very much for your time today.
Susan, thank you so much for your testimony. Does anyone have any questions? I don't see any. Thank you so much. And I hope you have a great day. Next up, number 22, Leah Cantor.
Good morning. Can you hear me?
Yes.
I'm incognito today.
That's fine.
Good morning. My name is Leah Cantor. Thank you so much for this opportunity to support raised House Bill 25227. My dad was a brilliant theoretical physicist. He was so focused that when he was earning his PhD in physics, he corresponded several times with Einstein for help on a physics problem that he couldn't quite grasp. Sadly, my dad developed dementia and ultimately required 24/7 live-in care, which we sought through a well-known home companion agency to care for him in his home. One day, I made my first unannounced visit and found my dad home alone. He didn't acknowledge me like he always did and seemed drugged. The caregiver returned shortly afterward and apologized for leaving him alone. My dad was disabled, minimally verbal, and couldn't walk without help. He could, however, stand up by himself, but would fall without aid. Our caregiver was required to submit a request to the agency if she wanted to leave. Given the opportunity through the court to provide evidence of that request, the agency chose not to. They also failed not only to not report the abuse to DSS as required by law, but failed to terminate her. Not one state agency has taken any accountability for the agency's failure to report the abuse. Documentation found led me to believe that the caregiver left my dad home alone dozens and dozens of times. Needless to say, I filed a lengthy complaint with the DCP almost 3 years ago. I learned that the DCP, as well as the police, believed that the caregiver had fraudulent multiple identities, and more importantly, the DCP reported that the agency had not been vetting their applicants properly. Of the nearly 36 local, state, and federal agencies I've reached out to looking for answers and accountability, I found none. The governor's office told me they wouldn't bother the governor with my issues, quote unquote, and DSS said they chose not to pursue it. For the past 3 years, I spent time digging and got a stifling education. I learned that the DCP works under Connecticut statutes and regulations, which merely encourages rather than requires home companion agencies to comply to. I learned that elder neglect is elder abuse in Connecticut, and if there's no injury, it's not criminal. I learned that it's the public's legal right to request a background check on a caregiver. I learned that DCP complaints and case files are made public through FOI. I learned that the DCP doesn't provide oversight for quality of care for home companion agencies. I learned that the agency didn't make a single unannounced visit to check in on my dad, and though not required by law, it's reasonable to expect at least one visit in 9 months. In fact, the DCP reported that the agency neglected to properly and sufficiently supervise its staff. I learned that the DCP reported that none of the employee files studied during an audit were fully reviewed, many lacking agency signatures, notarizations, and Homeland Security checks. I also learned that the DCP reported finding no evidence that the agency corroborated the legitimacy of the caregiver's 2 identities presented to the agency, even after the DCP brought up these concerns.
Excuse me. Sorry, your 3 minutes are finished now. Can you please summarize?
Oh, sure.
Thank you.
And mostly I learned that the agency has a decade-long documented history of misconduct and noncompliance, and a recommendation for revocation of certification. So in summary, I had nowhere to turn, and I feel strongly that a new position of a community ombudsman would be an asset to help people not go through what I went through, and to provide information that is just not out there for people. Thank you so much for your time.
Leah, thank you so much for your testimony. And I'm so sorry to hear what your dad and your family experienced. I appreciate your advocacy. Does anyone have any questions? I don't see any. Thank you very much.
Thank you.
Next is number 23, Jonathan Gonzalez Cruz. Are you on, Jonathan? All right, I don't see him. Next is number 24, Allison Ware. Hi, Allison.
Good afternoon, Representative Leeper, Representative Abercrombie, Senator Moore, and members of the Human Services Committee. My name is Allison Ware. I'm with Greater Hartford Legal Aid. I'm a policy advocate. I've submitted written testimony, so I won't read that here. I'll just answer a few points, highlight a few points. One, HB 2556. This corrects an error that was in drafting the bill last session to remove property liens against public act beneficiaries. The way the statute was drafted, however, it failed to remove a provision that maintained collection capabilities against beneficiaries in cases with children, which of course is all cases involving TFA and AFDC. This bill corrects that error. Commissioner Gifford cited a fiscal impact earlier during her testimony, but because this corrects an unintended exclusion of the TFA and AFDC cases, I believe that figure was probably accounted for in last year's, in LFA's last year's scoring of the budget for last session. On the budget, the governor's budget proposal, HB 5040, the governor's budget includes a lot of investments in important programs for human services, which are really a good step in improving our safety net. On the dental rates, I urge the committee to go further and raise the adult dental reimbursement to parity with the children's dental rate. However, the proposal also proposes cuts to TFA and SAGA, and those should be rejected. As we saw with the advanced child tax credit, cash distribution can reduce child poverty and food insecurity and support people working by providing funds for childcare and transportation. Cash is an effective way of helping people meet their needs. The cuts are proposed because caseloads have decreased, as they have steadily since the implementation of the TFA program in 1996. This may look like success, but it's really a sign that the TFA program is failing to help the families it's supposed to help. There are at least 4 contributing factors to this. 1, income eligibility levels have failed to keep up with inflation. 2, the 21-month time limit discourages people from enrolling in the program or throws them off before they get fully established. 3, asset limits discourage savings and place administrative burdens on the applicants. And 4, the low earned income disregard disqualifies families who earn as little as minimum wage in full-time jobs. The legislature could use these lapse funds to improve the programs in 4 ways. 1, change the standard of need to a measure based on the federal poverty level, which would automatically increase every year with inflation. 2, extend the time limits in accordance with SB 197. 3, remove the asset limits. And 4, increase the earned in disregard to keep pace with the increases in the state's minimum wage. Every time we increase the minimum wage, people working at full-time get that much farther out of poverty, and because the poverty income level is federal poverty level, people very low wage jobs and doesn't take much to get over that limit. On SB 194, I urge you take on the issue of extending time limits, which will still keep the program temporary, but gives people a longer period of time to actually get established in a job, to be able to cushion the problems that they might have in getting better established in a job. Our legal services clients have told us that the time limits are a barrier to enrollment, either because they've been discouraged by caseworkers in applying to do the time limits, or because they don't want to spend their 21 months unless they really need it. The time limit.
Excuse me. I'm sorry. Your 3 minutes are over. Please.
Certainly.
Summarize.
So I just hope the committee will take a look at my written testimony. There's also a slight inconsistency in the drafting of the bill of 197 regarding the penalties that I addressed in my written comments that I'd like you to take a look at as well. Thank you for the opportunity to testify.
Thank you so much, Allison, for your comprehensive and detailed testimony. Does anyone have any questions for Allison? I don't see any. Thank you. And I look forward to reading your written testimony as well. Appreciate that. Have a nice day. Next up is 25, Dawn Frey. Dawn, are you with us? All right, I don't see her. So next is 26, Elizabeth Frazier.
Hello, I'm just waiting. Here we go. Thank you very much.
You're with us.
Hi, I'm Liz Fraser. Let me just get my thing. And good afternoon, Representative Leeper, Senator Moore, Representative Abercrombie, and members of the Human Services Committee. My name is Liz Fraser. I am the Policy Director for the Connecticut Association for Human Services. a division of Advancing Connecticut Together. And thank you for this opportunity to provide testimony in support of Raise Bill 197. When we talk about TFA, we are talking about children living in poverty, over 100,000 children in Connecticut right now. And also children living in deep poverty, which is under 50% of the federal poverty level, including over 44,000 Connecticut children. The majority of these children are children of color. Yet over the past 20 years, the Connecticut cash assistance caseload has consistently declined, and at a much greater rate than the decline in poverty or even deep poverty. And this is not due to the success of the program or recipients. It has to do with eligibility income limits, how eligibility is determined, and the short time period that parents have to train or get a job. Fewer and fewer families are getting the assistance they need. And for their children to have a fighting chance, their parents need great support. Short of passing a comprehensive basic income support, we need to reform TFA. So we support extending the TFA time limit to 60 months, and it can be a game changer for these families. Research shows that reliable and stable support for a longer period of time, in this case 60 months, results in greater self-sufficiency and long-term benefits. Lapsed funds would be well spent on extending eligibility and providing stronger supports, including allowing extended education and training with necessary childcare so that recipients are able to participate in a career pathway program leading to supportable employment. We also have several other recommendations. The first is that you keep in place the progress that you made last year. The governor's budget does suggest eliminating some funding, and we really disagree with that. We also believe that using the federal poverty level to determine family eligibility rather than an outdated statement of need formula is really necessary. Just quickly, when a mom with 2 children is living in deep poverty, the family income is at the most $11,515. That is not enough for basic necessities, let alone rent or transportation. Yet using the current statement of need formula, this family may not even be eligible for TFA. This formula is far too constrictive, and is one reason why the number of families has decreased over the years. We recommend using 70% of the federal poverty level to determine eligibility. We also believe to eliminate the asset test, increase the earned income disregards, and to really start taking care of these children who are in such need. The purpose of TFA is to provide cash assistance to the most economically unstable families, creating a pathway to family economic stability. Cash assistance works. It helps families meet basic needs, can stabilize a family budget, promotes economic and racial equity, and helps children succeed. As demonstrated by the federal child tax credit, cash in the pockets of parents has been proven to move children out of poverty and increase stability in the family.
Excuse me, sorry, your 3 minutes are all over. Thank you.
Just one sentence. It's the only cash assistance in place, and it's specifically for those families. We ask that you do not keep leaving these families and children behind, unable to access the kind of life we would all like to lead. Thank you very much for your indulgence.
Elizabeth, thank you so much for your incredibly comprehensive testimony. Does anyone have any questions? Not seeing any. I appreciate you joining us today. Thank you so much.
Thank you.
Next up is number 27, Sarah Lemaster.
Hi, good afternoon, chairs and distinguished members of the Human Services Committee. My name is Sarah Lemaster, and I'm the Government Relations and Public Policy Manager for the Community Health Center Association. I'd like to thank you today for allowing me to speak on House Bill 5040. Connecticut's community health centers serve over 380,000 residents every year, and we specialize in providing care for traditionally underserved communities. We don't turn people away based on their ability to pay for services. Patients have access to same-day medical, dental, and behavioral health services. 20% of our patients identify as Black and 48% identify as Hispanic or Latino. A majority receive, 58% receive Medicaid benefits. Throughout the COVID-19 pandemic, our health centers have been working diligently to protect our communities and support our public health infrastructure. Our health centers provided over 930,000 COVID tests and fully vaccinated over 386,000 residents since August of 2020. In addition to that, we've switched gears many times to be able to provide services to our communities. And one of the areas that needs a lot of help right now is our provision of behavioral health services. House Bill 5040 adds behavioral health providers to the list of eligible recipients of funds from the state loan repayment program. This program was reestablished by the legislature in the 2021 budget. Adding these providers will give them access to student loan reimbursement, which will lower their debt burden and improve the ability of our health centers to recruit and retain providers. This is a separate program from the public service loan forgiveness programs and other types of programs available through the federal government. And this is specific to providers working in what is known as federally designated health professional shortage areas, which our health centers serve. Our health centers have seen a significant increase in the need for behavioral health services. In 2019, the average behavioral health patient saw their provider 9.1 times per year, and that number jumped in 2020 to 11.4 times per year. Additionally, our health centers have a long wait list. Many of our health centers have a long wait list of people who cannot receive services because there is not enough provider staff to support them. This student loan repayment program is an important tool in helping us recruit and retain providers. One of the issues that our health centers frequently are up against is the fact that they're unable to offer the competitive salaries that providers can get on the private market. And allowing people to apply for student loan repayment helps to make up part of that difference. The way that this program works is providers work in health centers for a minimum of 2 years. After that 2-year period, they can then apply for a loan repayment grant. This loan repayment grant is different from loan forgiveness because it shortens the overall life of a student loan. If you forgive $10,000 of someone's student loan debt when they're in a 20-year debt repayment plan, that reduces the amount of payments that people will make. This also means that those funds can go back into the Connecticut economy. Every part of their salary that providers can spend in our economy benefits Connecticut, as opposed to going to student loan services. I see Heather's popping up.
Hi.
I just wanted to thank you for your time, and I'm happy to take any questions. I've done a lot of work on the state loan repayment program, and I'm happy to be a resource to you.
Thank you so much, Sarah. Does anyone have any questions? All right, I don't see any. Thank you so much for joining us today and for your testimony.
Thank you.
Next up, number 28, Michael Finley. I see you there. Thanks for joining us.
Yes, thank you so much. Good afternoon, Senator Moore, Representative Abercrombie, Senator Berthel, Representative Case, and distinguished members of the Human Services Committee. Thank you for the opportunity to provide testimony before you today. My name is Mike Finley, and I wish to share comments in regards to House Bill 5225, an act prohibiting clawback of certain funds retained by nonprofit providers of human services under contract with state agencies. I am the Public Policy Coordinator at Mental Health Connecticut, a 114-year-old community-based nonprofit focused on person-centered, recovery-oriented care delivered through evidence-based practices. Our advocacy, community education, and services includes housing supports and wraparound services in Stamford, Bridgeport, Danbury, Waterbury, Torrington, and West Hartford. Mental Health Connecticut offers its strong support for House Bill 5225, which would prohibit the practice of state agencies clawing back surplus funds from nonprofits at the end of the fiscal year, allowing nonprofits to retain savings and reinvest them into the provision of services. If passed, this bill would promote efficiency and support Connecticut nonprofits' ability to operate using smart business practices. Community nonprofits are one of the largest industries in Connecticut, yet we are the most underfunded. The value of seeing community-based nonprofits as an investment in Connecticut's future heavily outweighs an outdated and inefficient practice that serves no one. It's time to shift our infrastructure so nonprofits across the state can be supported to reinvest in the future of Connecticut residents. This is not the first time we've come before this committee to stress the importance of flexibility and funding for nonprofits. But the past 2 years have been unique in that COVID-19 has demonstrated exactly how illogical it is that nonprofits were forced to pay money back to the state in the midst of a deadly pandemic. Our experience at Mental Health Connecticut in both 2020 and 2021 proved that being nimble is critical to success. On a dime, we had to shift programs, roles, how we work, when we work, and what we delivered to take care of the people we serve and our staff. Living in a code red type situation of a pandemic and social unrest will not be our normal moving forward, but it's clear that strong, resilient organizations like Mental Health Connecticut must do all we can to be flexible and agile for any unexpected situation that comes our way. Despite support from this committee for the nonprofit community since 2017, the innovation program has yet to be implemented. We think this year, above all others, has heightened the sense of urgency and need for this program. I thank the committee for raising this important bill and urge you to support House Bill 5225. Thank you for the opportunity to testify on this important legislation. Thank you very much.
Thanks so much for your testimony, Michael. Does anyone have any questions? All right, I don't see any. Thank you.
Thank you.
Next up, number 29, Doug Ardrey.
Good afternoon, Senator Moore, Representative Abercrombie, Senator Berthel, Representative Case, and members of the Human Services Committee. My name is Doug Ardrey. I am the Chief Financial Officer of SARA Inc. Our organization provides early intervention, birth to 3 services, as well as employment, day support, and residential services to adults with intellectual and developmental disabilities. In our current capacity, we serve approximately 1,400 families and individuals per year. Our organization has been in existence over 60 years, employs approximately 130 Connecticut residents, and operates in 5 Connecticut counties. Thank you for the opportunity to provide testimony in support of HB 5225, which would prohibit the practice of state agencies clawing back surplus funds from nonprofits at the end of the fiscal year, allowing nonprofits to retain savings and then reinvest them into provisions of services. Despite the legislatures already having passed 3 laws to eliminate the practice of clawbacks, state contracting policies continue to mandate the nonprofit savings must be returned to the state. As the CFO of SARA Inc., it is my responsibility to maximize every dollar of revenue that the company earns. We strive to run our business as efficiently as possible and spend very wisely. Because of the way that we run our business, we usually do have a surplus at the end of each fiscal year. And currently, we either have to spend that money before the end of the fiscal year or return it to the state. If we were able to keep those surplus dollars, it would be a huge incentive, not only for our company, but for other nonprofits to maximize the efficiencies in our businesses. Allowing us to keep those surplus dollars would also enable us to strengthen our balance sheet and increase our reserves for future economic downturns and other unforeseen circumstances, such as the current pandemic. By letting us keep the surpluses at the end of each year would allow us to make investments in our business that current funding does not allow for, such as competitive employee wage increases and investments in vehicles and other equipment necessary for us to run our business. We usually have to find other grants and donations to supplement these costs. Improving the financial strength of nonprofits is a win-win for both the funding agencies and services providers. For 5 years now, we have come before the committee to stress the importance of flexibility in funding for nonprofits. But this year is exceptional in that COVID-19 has demonstrated exactly how illogical it is that nonprofits were forced to pay money back to the state in the midst of a deadly pandemic. Despite support from this committee, the legislature, and nonprofit community since 2017, the innovation program has yet to be implemented. This year has heightened the sense of urgency and need for the state to end the practice of clawing back surplus funding. I thank you for your time and your consideration related to passing HB 5225.
Thank you so much, Doug, for joining us in your testimony today. Does anyone have any questions? All right, I don't see any, but appreciate you joining us.
Thank you.
Thank you. Next, number 30, Kathleen Holt. Hey, Kathleen.
Thank you. Representative Leeper, Senator Moore, Representative Abercrombie, ranking members, and members of the Committee on Human Services. Thank you for the opportunity to provide this testimony. I'm Kathleen Holt, Associate Director and Attorney for the Center for Medicare Advocacy. My legal practice focuses on access to Medicare-covered care, particularly home health care. I'm here to speak to Bill number 5227, an act establishing the Community Ombudsman Program for home care. The Center for Medicare Advocacy strongly supports such an ombudsman's program, but it should be expanded to assist all Connecticut residents navigate obstacles to care at home, prevent misuse of public funds, and protect residents in their homes, especially Connecticut's vulnerable older or disabled residents. Such an ombudsman's program should not be limited only to Connecticut citizens in programs administered by the Department of Social Services, as the bill is currently written. Rather, it should be modeled after the current long-term care ombudsman's program. That program is directed to improve the quality of life and quality of care for all Connecticut citizens who live in nursing homes, residential care homes, and assisted living communities. Protections that arise from a new community ombudsman program for home care are critical for and should apply to all Connecticut residents receiving care at home from providers. The Center for Medicare Advocacy regularly hears from Connecticut Medicare beneficiaries who have concerns about the services they are or are not, but should be receiving at home. Too often, these individuals fear reporting their concerns will result in retaliation from their home health provider. The ombudsman would be welcomed into someone's home to uncover and address any abuse and neglect and ensure ordered home care services are effectively provided. A community ombudsman program for home care expanded to include all Connecticut residents, not only for individuals served by the Department of Social Services, would also provide oversight onto state Medicaid programs for individuals who are duly eligible for both Medicare and Medicaid. The Center for Medicare Advocacy is concerned that too much home care that should be covered by Medicare is being billed to and paid for by Medicaid. In summary, the Center for Medicare Advocacy urges the legislature to establish a statewide community ombudsman program for home care for all Connecticut citizens, not just for individuals who are eligible for Medicaid. There is significant need for protection, oversight, accountability, and reform that such a community ombudsman program would provide. Thank you for your time, your consideration, and your work on behalf of Connecticut citizens.
Thank you so much, Kathleen, for joining us today and your testimony. Does anyone have any questions for Kathleen? All right, not seeing any. Thank you so much for joining us. Next, number 31, Kathleen Hayes. Are you with us, Kathleen Hayes? All right, not seeing you. Number 32, Dawn Van Wagenen. Dawn, are you with us? All right, not seeing Dawn. Number 33, Joel Sikorsky. And I apologize if I did not pronounce that correctly.
Oh, you nailed it. You're good. Good afternoon, everyone. My name is Joel Sikorsky. I am the president of the Connecticut Association of Senior Nutrition Providers and the director of elderly services for the city of Torrington. We do Meals on Wheels for the 18 towns in the northwest corner. I'm here to talk about Bill HB 5231, malnutrition data collection for seniors. I did submit written testimony, so you can go through that. And I'd just like to take a minute to talk about what the bill can do and address some of the concerns from the ADS from earlier this morning. The bill in its intent will track malnutrition for seniors that are receiving Meals on Wheels. We can put that data together and prove the claims, hopefully, that we've been making what Meals on Wheels does for people in their homes. As many of you know, seniors lose their appetite when they get older. If they don't have Meals on Wheels in front of them, they may not eat at all. So all of those things we believe are a benefit to malnutrition, and we lack the tool to track that and get it together. So hopefully that's what this is going to do for us, and we'll be able to then advocate and continue to properly fund ourselves and be out there delivering meals in the future. Also, I did listen to Commissioner Porter's testimony this morning from the ADS, And we totally agree with getting rid of the language for NAPIS. I was not aware that that changed in our worlds. We deliver meals. We don't pay much attention to what we're calling things these days. So that would be great to have the proper language in there, what we're calling the tool today. Also, we agree that it's a lot of extra work, but I don't know if a lot is a term when you get the benefit that you get. And the data is certainly there that we're collecting. And without making a stab at it in the first year, and I'll allude to, not allude, but I'll echo what Rep. Cook said today. I think that getting it done in the first year is the right way to do it. We can see if their new tool works, if it's asking the right questions, and if it's preparing the data in the way that it should be. Through the assessment and using that tool, we should be asking the right questions. And what better way than to make the report the first year and find out if the new tool is doing all the things we need it to. It's a bit longer than we used to do. That we as a group did push back on that new tool initially because it was a lot more work. But I think when we all sat down and realized, you know, and talked and worked it out with them, that it was worth the effort and to try to move forward and get all the new clients on that as soon as possible, because we do need to track these things. It's a data-driven world, and we're looking to make sure that we're utilizing the funds best we can. I'd be happy to take any questions.
Joel, thank you so much for joining us today in your testimony, and thanks for everything you do to ensure so many seniors get nutritious meals. I see Rep. Cook has her hand up.
Thank you, Representative Leeper. I appreciate it. Joel, great to be here, and thank you for partnering and really leading the charge on this conversation with the group of folks that you work with and do such great work. I want to just clarify there was kind of an insinuation that we would possibly be looking to take from one to give to others. And I want to make sure that that is very well clarified, that that is not the intention at all, but it's more along the lines of trying to get more for all. Could you just make sure that we're on that same page, please?
Yeah, I don't 100% understand the ask for rural versus urban and how that got tied into this. But the way I see the data being used is it gets sent from Connecticut up to Washington. The ACL then gets to see that. It's used for the Older Americans Act when they do the White House Conference on Aging and things like that. And they can add more funding to the program in general, which would then filter down to the state of Connecticut. It would bolster all of our asks for additional funding, and then that would be distributed by formula. Change in formula is not something that I could even possibly talk of on my level, but the intent is to get more funding because we can prove now that seniors with malnutrition are getting better with the use of Meals on Wheels. That to me is the core of this. I'm sure the way things are written, somebody can interpret it the way that they want to or the way they see it. But I think the intent is clear that we just want to say there's malnutrition among seniors. Meals on Wheels gives them food in their house. They get stronger, they get better, they go to the hospital less, they stay in their homes where they belong. And that's all part of it. So by tracking this data more cohesively, we can then prove that and utilize it when we're making our spiels like I did today.
And I want to thank you. I mean, you all really thought out of the box during this pandemic and made sure that our elderly were fed in some of the most unique ways. And I would have to say, and I'm bragging a second, and I'm sorry, but we, you know, when you start having, you know, outdoor picnics and 50s events and, you know, all sorts of theme events in a parking lot because people need to be socially distant and they can't come into a building, there is truly something to be said about your dedication to our seniors. And the drive up deliveries that you all were doing, I just can't thank you enough for taking care of our corner and doing all of the stuff that you and your staff do and bringing this to our attention. And so thank you for your continued advocacy. Thanks, Rep. Leeper. I appreciate it.
Thank you.
No problem. Thanks, Rep. Cook. And thanks again, Joel, for both your testimony and everything you've done. Appreciate it. Any other questions? All right, not seeing any. Have a great day.
You too. Thank you very much.
I think number 31 has joined us. Kathleen Hayes, are you with us? There you are.
Yes. Thank you.
Good afternoon, Representative Abercrombie, Senator Moore, and distinguished committee members. It is my distinct privilege to testify today in support of Senate Bill 195 on behalf of the Elder Law section of the Connecticut Bar Association, as well as the Connecticut chapter of the National Academy of Elder Law Attorneys. So in essence, Senate Bill 195 seeks to increase the minimum amount of assets that a community spouse is permitted to keep in a long-term care Medicaid application. And the people that will really be most impacted by the passage of this bill are individual couples that have combined resources of $99,000 or less, as well as women who are often more disparately impacted in the long-term care Medicaid application process. So I'd like to give you an example of a family that would be positively impacted by the passage of this bill. The example is a couple where the couple's combined resources are $50,000. Under the current law, the Department of Social Services, when you submit a Medicaid application, will in essence split the couple's assets in half. And the ill spouse is permitted to keep $1,600, and the well spouse is permitted to keep half of the assets, subject to a maximum of $137,400 and a minimum of $27,480. The passage of Senate Bill 195 would increase that minimum amount from $27,480 to $50,000, which is an increase of $22,520. So if you have a couple with $50,000, the ill spouse can only keep $1,600. The well spouse, half of their assets is $25,000. So they would be, under the current law, permitted to keep $27,480, and through the passage of Senate Bill 195, they would be able to keep $50,000. Now, it might seem a modest sum to increase by that $22,520, but it really is the difference between being able to pay your mortgage, be able to pay grocery bills, and be able to sustain your life outside of assistance provided by the state. In the past, and even today, the Department of Social Services has opposed any sort of legislation that would increase not just the minimum amount of resources that a community spouse can keep, but also other legislation previously proposed that would allow an individual to keep up to the maximum. And today, the commissioner testified that there would be a fiscal impact of about $4.5 million. Now, the Department of Social Services has never provided any sort of evidentiary documentation supporting such a fiscal impact, and it really belies common sense that savings of around $22,520 per couple would really impact fiscally in this way. And in fact,
sorry,
yes.
excuse me, your 3 minutes are over. Please summarize.
Oh, thank you. So I would respectfully request the support of Senate Bill 195 so that we can start to move forward in our state toward protecting lower and middle class families, as well as women who are disparately impacted by the current legislative structure. And I'd be happy to answer any questions.
Thanks so much, Kathleen, for your testimony and for joining us today. And I appreciate your comment on the disparate impact on senior women of the status quo. I see Rep. Hughes has her hand up.
Thank you, Madam Chair, and thank you, Kathleen, for this really detailed testimony. Can you just tell us when a couple applies for Medicaid and for the ill spouse, like you said, and they're retaining assets? That application is only for the ill spouse. Is that correct?
So the application, when you have a married couple, and you have generally, so the ill spouse is the person that is the applicant, and then the well spouse is who we refer to as the community spouse. When you apply for Medicaid and you're married, the state looks at the combined assets of the couple, regardless of which one is the applicant.
Yeah, I understand that. I was just thinking practically in terms of spouses applying for Medicaid eventually, that cost to the community spouse, if you will, is still borne by that community spouse sometime in the future. Is that correct?
Yes,
For
absolutely.
the application, right? So we're talking about a very involved process for the ill spouse, which is costly, by the way, which we testified to about earlier. And we're trying to retain community assets. Well, we're trying to retain assets for the community-based spouse that might also include applying for Medicaid in the future. Is that correct?
Yes, and part of our contention, the elder law and NALA, is that there would be cost savings to the state if we are allowing a community spouse to keep more resources, because so often what we see is individuals that no longer have resources to provide for their own care, their own bills. So they're now applying for long-term care Medicaid and costing the state these millions of dollars that otherwise would be avoided if we allowed them to be self-sufficient with their own resources.
Right, perfect, thank you. I just wanted to clarify that sort of arc of need, basically, and what we're trying to conserve, I would say, more assets, like you said, to create more longevity, self-determination in the home with supports and care, community-based. So thank you.
Absolutely.
Thank you, Rep. Hughes. Anyone else have any questions for Kathleen? All right, not seeing any. Thank you so much for joining us today and for your testimony.
Thank you for having me.
Next up is number 34, Ben Shaken. Thanks for joining us.
Hi, good afternoon, Madam Chair, members of the committee. Thank you for having me this afternoon, and thank you for the opportunity to provide testimony in support of House Bill 5225, an act prohibiting clawback of certain funds retained by nonprofit providers of human services under contract with state agencies. Simply put, this bill would end the practice of state government clawing back unspent funds from human services providers at the end of each fiscal year. It would allow nonprofits, as you've heard today, to retain savings and reinvest those savings in their organizations in the provision of services. We have been in front of this committee for 5 years. You have my written testimony, and so I won't go through it, but I just want to point out that amid the pandemic, we asked nonprofits what would help them navigate their challenges the most, and they said flexibility. And instead, in both 2020 and 2021, despite the state receiving billions in federal relief dollars, at the end of each of those fiscal years, nonprofit providers paid unspent state funds back to the state. And now, as we sort of emerge from the pandemic, nonprofits are struggling with a historic workforce crisis. We found in a recent survey that nearly 1 in 5 nonprofit jobs are unfilled. They have used these vacancies. They have funded wage increases with the vacancies in their organizations, funded hiring and retention bonuses more and more, all to try to keep their services operational. And so if these funds are again clawed back this year, there's going to be significant financial consequences for community nonprofits. Just to provide a little history and some reaction perhaps to the commissioner's testimony earlier, this is the 5th year, as others have mentioned before the committee. This legislature passed a law in 2017, 2019, and then several different things last year in 2021, including Public Act 2165, which passed the legislature unanimously, and Section 375 of the implementer, as well as the removal of 2 heretofore standard sections in the state budget, which authorized the practice of clawing back funds at DDS and DMIS. And unfortunately, despite the legislature's sort of repeated action and desire for this practice to change, the program that these bills created has not been implemented. And so we are here on March 1st, 8 months into the fiscal year, beginning the last third of fiscal year 2022, without any implementation details from the executive branch around the innovation incentive program around allowing human services providers to retain that revenue. And so we appreciate the committee raising this bill, which would instead outlaw the practice of clawing back those funds. In addition, as Representative Abercrombie mentioned earlier, the judicial branch has informed providers that their legal team has determined that they are not subject to the 2021 legislation. And so this bill would change the definition of human services providers to clarify that the legislature intends for the judicial branch to be involved in it. I will just offer a quick reaction to Commissioner Gifford's opposition earlier. And just to say, I see Heather's face coming on, which means I'm out of time. So just to say in summary that similar to Representative Abercrombie's reaction, the opposition for Medicaid-based reasons is news to us. And I will point to the fact that since the pilot program in 2019, which as it was implemented involved only DDS providers, we have not heard any mention of there being Medicaid implications to this policy. And DDS providers have been over the years, including recently, allowed to retain a certain percentage of their surplus year after year. And so we are surprised to hear of that source of opposition, but we are, of course, always open and willing to make sure that whatever the legislature passes this year will be in compliance with federal Medicaid law. So I'm happy to answer any questions. I will have also submitted testimony around the student loan program in House Bill 5040, but I'm out of time, so I can't talk about it right now unless someone would like to know more. So thank you very much.
Thank you so much, Ben, for your very comprehensive testimony and your advocacy around these issues. Does anyone have any questions? I don't see any. I trust that your written testimony also includes everything you didn't get to. Thank you so much for joining us today, Ben.
Thank you.
Next up, number 35, Christy Scott. Are you with us? There you are.
Yes. Can you hear me and see me?
Yes.
I'm not great at this. Should not be. I should be a professional at it with all these Zoom meetings, but
you're doing perfect.
So hi, I'm Christy Scott. I'm the CEO of Perception Programs in Willimantic, and I'm here to testify in support of HB 522. Ben detailed a lot of what that bill does, so I'll skip through some of that detail. Being the CEO of a nonprofit, we deal with this directly every single year of having to carefully monitor our budget, also have very little control over vacancy savings, which is what something called when we don't have a position filled, we have a vacancy savings. And the end of that all, at the end of the year, we have to give that money back to the state. And it's very aggravating because we have high cost and turnover. Turnover costs money in so many other ways. We've done many special initiatives to hire staff. So if we could keep that vacancy savings, that would help fill that. Instead, we have to write a check and give it back to the state. Even if our entire budget is in a deficit, we're still giving money back. It's actually the craziest thing I've really ever heard of. If you do any other contract, you don't, if they contract for a builder to build a bridge, I don't think at the end of it, they don't say, oh, well, you owe us 1.5 million. Please write us a check back. It's just not how it works. So it's very disheartening that this is the third time I've testified on this. As Ben mentioned, it's been brought up many times, but not fully implemented to the broader human services sector. The example I have is not through a Medicaid program, so I'm not sure the effects of it on a Medicaid program, but we have a particular program. Again, we had a vacancy savings, but we had a loss in that program, but we still had to write a check back for $13,600. And this is after a COVID year where we had to give everyone incentives to work during COVID. We had all these other expenses, yet we still had to write that check back. I have another example of Demas is actually asking for a large amount of money back from a 2016 budget that was approved, balanced, and now they're asking for this money back, and we were hard pressed to even figure out why. So it's frustrating that we live on a shoestring budget and that we have not had real contract COLAs in 12 years. We've gotten a small percent for staffing that we appreciate, but this goes on, and at some point we are not going to be able to make ends meet with this type of model. So thank you very much. And I have also submitted written testimony, which is a little bit more succinct. Thank you.
Thanks so much.
I'm happy to answer any questions.
Really appreciate you joining us today, and thank you for your testimony. Does anyone have any questions? All right, seeing none. Thanks a lot. Next up, number 36, Matt Barrett. I see you there.
Hi, good afternoon. My name is Matt Barrett. I'm the president and CEO of the Connecticut Association of Healthcare Facilities. And I'm here to testify on Senate Bill 196, an act prohibiting discharges from nursing homes and residential care homes to temporary or unstable housing. We acknowledge our healthcare and human services delivery system is failing in the area of long-term services and supports when the result is an involuntary discharge of a nursing facility resident to temporary or unstable housing. Housing instability is directly related to health outcomes, and discharges to unstable housing circumstances is underserving a population in our healthcare system that needs more help, not less help. However, such a proposal, we believe, should be accompanied with broader reforms. Therefore, we're recommending additional measures beyond what we view to be the narrow and simple prohibition kind of approach in the bill. First, the bill should establish a funding mechanism to reimburse nursing homes when the facility is unable to transfer or discharge a resident and the resident has been determined to be ineligible for Medicaid-covered nursing facility services due to level of care requirements that are no longer met because the individual's health has improved. Second, our nursing homes will need to intervene earlier in these challenging cases, or they may need to evaluate that they will be unable to address the new housing requirements prior to admission. Therefore, we're recommending that individuals, hospitals, or other entities be required to disclose to the nursing facility prior to admission if the individual is experiencing or has a history of experiencing housing instability. And third, again, towards intervening as early as possible in the implementation of discharge planning requirements, the nursing facility should, in a timely manner, seek the assistance of an area coordinated access housing agency or other local entity specializing in housing services towards the earliest possible intervention in addressing these difficult and challenging housing situations that exist for so many in Connecticut and we see in the nursing home environment. We're asking that cases that fall under this category become priorities in the Money Follows the Person program to the extent that that is possible, and in the new CHESS initiative that DSS has now begun implementation of. I've submitted substitute language to the committee for their consideration concerning our recommendations, and I'd be happy to answer any questions that you may have.
Thank you so much, Matt, for your comprehensive testimony. I see Chairwoman Moore has a question.
Thank you, Madam Chairwoman. You're doing a great job too. Hi, Matt. How are you?
Hi, good afternoon, Senator Moore.
So I have a question. You said in your statement it would be helpful if you knew ahead of time that the person coming to you had not stabilized housing. Is that correct?
Yes.
And how would that impact your how would that impact you in your decision to take them?
I think two issues come into play there. One, there are really harmful consequences to the nursing facility if they didn't fully appreciate. This is under the assumption that this bill passes and that there would be an outright prohibition to discharging to temporary or unstable housing. But in the event that that provision were to become law, then the consequences of the nursing home accepting that admission without good knowledge that they were taking on a case that would require a comprehensive intervention to try to address the housing situation. And if they weren't able to do that, they may be in a situation where Medicaid eligibility would be terminated and they'd be unable to discharge the resident. So it just elevates the importance of, in the admission process, the facility having a deep and thorough understanding on whether or not the client is experiencing current housing instability, which really perhaps led to their hospitalization in the first instance. Many of these cases are coming from the hospital, or if they have a long history of experiencing that. It just informs the decision about whether or not they have the ability or staffing to accept the resident in the first instance. That's number one. Number two, it says to the nursing facility that if you do take this admission, then you really must begin an enhanced and exhilarated discharge planning process, addressing the housing instability that was known to you on admission. And if you don't, you could end up in a similar situation where you're unable to discharge and Medicaid is no longer a payer source. So it becomes important both in both those dynamics, Senator Moore.
And where would you place that during what interview or what process? Where in the process would you want that to appear?
The principal one that occurs is in the process by which the admission is coming from by way of a hospital. That's the most common occurrence, and there is a detailed referral form that accompanies that. And so I think that will probably be the best place for it. But in addition to that, there's a lot of interaction between hospital discharge planners and nursing facilities that take place by way of electronic means and emails and telephone calls. And it should be a commonplace, piece of information that is being discussed, in that process. Now, I do want to say that doesn't absolve the nursing facility in any way, shape, or form of taking it on their own responsibility to learn about this from their end as well. And so it's sort of a two-way street. The referring entities should disclose it, and the nursing home should have sort of enhanced awareness that it's a very important piece of information, again, in the event that a piece of legislation like this were passed.
Thank you. Thank you, Madam Chair.
Thank you, Senator Moore. Thank you so much, Matt. Is there anyone else who has any questions? All right, seeing none. Thanks, Matt, for your testimony today and also submitting your proposed substitute language. I appreciate that.
Thank you so much.
Have a great day. Next up, number 37, Karen Siegel. Thanks for joining us.
Good afternoon, esteemed members of the Human Services Committee. My name is Karen Siegel. I serve as the Director of Policy for Health Equity Solutions. We are a nonprofit organization with a statewide focus on promoting policies, programs, and practices that result in equitable healthcare access, delivery, and outcomes for all people in Connecticut. Thank you for allowing me to testify today on the governor's proposed budget for the Department of Social Services. I'm going to just quickly summarize the written testimony that we submitted. Connecticut's health insurance landscape is growing increasingly complex, and tens of thousands are at risk of becoming uninsured. There will, in fact, be hundreds of thousands of Medicaid redeterminations at the end of the public health emergency. And we believe that funding trusted messengers to connect people to care could prevent a loss of insurance and gaps in care as this change happens. New programs created to provide affordable coverage for more Connecticut residents, including Covered Connecticut and Husky access for a small subset of undocumented immigrants, are truly important steps toward addressing inequities in insurance coverage. But for those who remain ineligible for Husky, or for those who become eligible for covered CT in the months ahead, the process can be confusing regardless of which category you fall into. And for those who do successfully enroll in Covered Connecticut or a qualified health plan, they'll experience changes in their covered benefits and provider networks and might not be aware of this or of the wraparound benefits that Covered Connecticut will soon provide. These programs will only have their intended impact if people are able to enroll in and utilize them. And to ensure that that happens, that people can remain insured, enroll in new programs, and use their insurance coverage, we strongly urge funding community-based health insurance navigator supports. Next, I wanted to just quickly note that ensuring access to health insurance for all immigrants in Connecticut is a crucial part of advancing health equity in the state. Despite the important steps taken last year, many immigrants remain ineligible for Medicaid and unable to purchase health insurance in the state, and this contributes to inequities in coverage rates. In addition, many Connecticut residents remain without options for insurance that they can afford to both enroll in and use. Just for example, a family of 4 that's earning just above the eligibility limit for covered CT and covering 2 adults could spend up to $14,300 in premiums, deductibles, and cost sharing if they needed to use their insurance. And that's over 26% of the family's annual income. And finally, I just wanted to note HES's strong support for increases in Husky adult dental and endodontic provider rates, and recommend aligning adult and child dental rates in Husky to increase access and address inequities in oral health care. And thank you all for your time.
Karen, thank you so much for your testimony today. Does anyone have any questions? All right, seeing none, I appreciate you joining us. Thank you. Next up, number 38, Fernando. I see you right there. Thanks for joining.
Good afternoon, Madam Chair, members of the Human Services Committee. My name is Fernando Muñiz, and I'm the CEO of Community Solutions. We provide residential and community-based services for youth and adults involved in the criminal justice, juvenile justice, and child welfare systems. I'm here to testify in support of House Bill 5225, which would end the practice of state agencies clawing back surplus funds from nonprofits at the end of the fiscal year. I just want to highlight a couple of points from my testimony. One is that this would not add any additional expense to the state of Connecticut budget. These are dollars that are already appropriated and included in our contracts. In program years where we run a deficit, we have to fill the gaps with private donations and foundation grants. But in programs where we run a surplus, we have to return the funds to the state. And this is not how the state purchases goods and services from for-profit companies or consulting firms. And it's wholly unfair to nonprofit service providers to expect us to deal with this as the contracting norm. In the last 3 fiscal years, my organization has returned approximately $800,000 to state agencies in savings from our programs. Now, that's an unusually high number. We're a fairly large service provider with $15 million worth of contracts with the state. But in spite of meeting all of our contractual obligations, we were required to return these savings. These dollars could have been spent on expansion of services to clients, better wages for staff, or improvements to our physical plant. In the summer of 2020, during the first wave of the COVID pandemic, we returned approximately $120,000 to the state. Even though we were running some deficits in other programs, these funds could have been used to pay for hazard pay for staff, personal protective equipment, or to cover deficits in those other programs. Despite the support from this committee, the legislature, and the nonprofit community for over 5 years, the innovation program that you passed into law still has not been implemented. And I'm here to ask for your support in continuing to push this forward with the executive and legislative and judicial branches. So thank you very much.
Thank you so much, Fernando, for your testimony and joining us today. Does anyone have any questions? All right, seeing none, thank you so much. Next up, number 39, Bob Blancato.
Thank you, Chair Leeper. And as the national coordinator of the bipartisan National Defeat Malnutrition Today Coalition, I wish to lend our support to Bill 5231, an act concerning data collection to prevent malnutrition among senior citizens. I commend the bill's sponsors, Reps. Michelle Cook and Michael Winkler. Also, thanks to Representative Ann Hughes for the invitation to testify today. This committee is appropriately focusing needed attention on the growing problem of older adult malnutrition. It is a threat to the health of older adults. In fact, according to our national blueprint, before the pandemic, 1 in 2 older adults were malnourished or at risk of malnutrition, defined simply as lack of proper nutrition. Nutrition-related hospital stays are 2 times longer, and disease-associated malnutrition in older adults is estimated to cost over $51 billion annually. Bill 5231 recognizes the importance of data collection. After all, you cannot address what you don't know. In addition, good data can drive dollars where they should be directed, in this case, to help prevent malnutrition. It is also important to understand the value of prevention when it comes to malnutrition. As my friend Joel and our friends at CANASP said so clearly, many common chronic conditions such as hypertension, heart disease, diabetes, and osteoporosis can be prevented or risk reduced with proper nutrition. Put more simply, it is about what you eat. Poor nutrition leads to malnutrition. Our focus going forward should be on promoting nutrition security for persons of all ages. Finally, Bill 5231 comes at a time when at the federal level, the Older Americans Act includes malnutrition screening for the first time. Proper screening can contribute to amassing data that can determine the best use of resources, whether they be state or federal. I hope Bill 5231 can be passed quickly, perhaps by May, to coincide with Older Americans Month. Its passage will show that Connecticut truly cares about preventing malnutrition among its older adults and supports the important aging network of area agencies and service providers who work every day on behalf of older adults. Thank you very much.
Thank you so much, Bob, for your testimony. I see Representative Hughes has a question.
Thank you very much, Madam Chair, and thanks, Bob, for blending your federal or national perspective on where this fits in with the national landscape. And also, I just wanted to drill down to the 1 out of 2 or 1 out of 3 that could be suffering or at risk of malnutrition. First of all, do you think that our bill, in terms of the timeline, is aspirational or doable in terms of getting this data collection up and running? And do you think that we, because of our geographic smallness, Connecticut can effectively collect the data to respond in real time to the needs here in Connecticut?
Yeah. I think yes on both counts. I think it's doable. I mean, I think there's enough data collection that's going out there that isn't as valuable as this could be, in all honesty. And there isn't a service provider I know in your state who wouldn't agree with that. And I think what you have to do is recognize in the geographic differences that there are. Outreach becomes very important in how you achieve the information that you're getting. And I think that what I'm concerned about, and I'm sure Representative Cook and others are as well, is the downstream after the pandemic of what we're going to find. Okay, and I work also in the field of elder abuse, and know that's another concern we have about what we're going to find when everything settles. So it's important to get the mechanism in place right now to know what you're asking, to get that data, but then put it together quickly so that you're able to put it forward and then have that lead to a response in terms of more resources. So I feel comfortable knowing what I know about Connecticut that this can be achieved very easily.
And finally, are there any states doing this better?
I will double check. I think based on a couple of things we know, Ohio has some pretty good record in that area. Massachusetts has a pretty good record in that area. And Florida was beginning to move in that direction. Let me submit some information back to the committee and see what we can help on that point.
Thank you so much, Bob. Thanks for being here and lending your expertise.
Thank you very much.
Thanks, Rep. Hughes. Thanks, Bob. I see Rep. Cook also has her hand up.
Thanks, Rep. Leeper. And Bob, thank you so very much for being here. I greatly appreciate it and all the work that you're doing at the national level. And Representative Hughes asked a couple of the questions or points that I wanted to make, but I do have a question that maybe you might be able to go a little bit more in depth with. When we're talking about connecting the state and the federal dollars, and what a report and data collection like this would look like potentially for us as a state and for our seniors, and those doing all the great work for them, would look like having this information.
Yeah, that's a good point. And why it's relevant now, especially, is because, as many of you may know, Congress passed 4 different emergency pandemic bills. And in those 4 bills, the Older Americans Act Nutrition Program alone got $1.6 billion in emergency funding, based on the fact that the whole program got converted, as many of you know. 2/3 of older adults were served in congregate settings before the pandemic. A month after the pandemic, over 95% were being served in home delivered meals. So in other words, if you served 100 people in a senior center one day, the next day you had to serve them in 100 different places, meaning you have higher costs of transportation, higher costs for food, et cetera. So when the time comes for the allocation of dollars, what's going to drive that conversation is the increased need that's been about because of the pandemic and related normal growth of the older adult population. So in my judgment, the case that's made strongly in this situation is gathering the necessary data to prove the need for the money. And I think that's clearly why you collect data. At least in this bill, that's how you collect data. And I'll throw in, since I'm down here in Washington and she happens to be a longtime friend, you happen to have the chair of the Appropriations Committee in the House, of Rosa DeLauro there, who loves this issue, who loves this program. I've testified before her at least 3 times on this point, and we wouldn't have that extra money from nutrition had she not stepped up and led the fight on that. So I know this will be of interest to her and seeing how this data is collected. And trust me, you are ahead of the curve on the issue of malnutrition. We've got 3 focuses here. We have senior hunger, which we care and concerned about and addressing. Food insecurity, we're also concerned about and addressing. we have not necessarily addressed malnutrition, which is really the consequence of those other two. So I commend your focus on malnutrition and older adults as we go forward, and happy to work with you as best we can.
Bob, thank you so much. And we will definitely take you up on that partnership. And it means a lot having you here to be able to testify on such an important piece of legislation. Keep up the great work out there. Thank you so much.
Thank you. You guys as well. Thank you very much for inviting me.
Thanks, Representative Cook. And thanks so much, Bob, for your expertise and your time with us today. I really appreciate it.
My pleasure. Thank you.
Next up, number 40, Ann Wilson.
Thank you. Madam Chairs and distinguished members of the Human Services Committee, my name is Ann Wilson. I always appreciate and I'm grateful to have the opportunity to testify before you. I speak, as always, on behalf of my elderly parents who benefit from home care services, as well as being the client services manager for Companions and Homemakers, which is one of the largest and longest running non-medical home care agencies here in the state of Connecticut. And we've participated on the Medicaid funded side of things since 1990. With the upcoming budget, I am here certainly to talk today, as many others have, about the financial crisis we're facing in continuing to deliver these essential care services. Non-medical agencies operate 24 hours a day, 7 days a week, 365 days a year. We were fully operational throughout the COVID pandemic crisis. We continue to be through inclement weather in New England. And like our counterparts in healthcare, we're 24/7. We serve not only hundreds, but thousands of elder clients throughout the state of Connecticut. I did submit written testimony. I'm going to go a little bit off script just simply because I happened to pop on WFSB before I testified here today, just to catch up on some news. And I saw that they announced nationally that the Target chains, excuse me, are currently paying $15 an hour. And because of the staffing crises and shortages we're all facing, they're going to be starting up to $24 an hour for entry-level workers, depending on where they are in the country. Best Buy's followed suit. Costco's at $16 to $17 an hour. Amazon pays $15 an hour minimum and $18 for driver. With the current Medicaid reimbursement rate for our care workers at $16.88 an hour and the increasing minimum wages, we can't remain financially competitive or viable. There's no way that we can continue to recruit and retain the workforce that we need to provide these essential services. Sometimes our services are considered non-essential, companion, homemaking, personal care, but let me stand before you today and say they're absolutely essential. With the crisis in healthcare side of things, there's no way that the healthcare sector within the home that we partner with could pick up the home care slack. Many of the clients that we serve, being elderly, they're not in the position to self-direct their care. They don't necessarily have the capacity to do that, nor do they have the support systems. So what I'm pleading with you today, first of all, I do want to say that in support of the Ombudsman program, we do think that is something that is beneficial, and we are in support of that. But I'm asking you here today to please help make us whole and maintain these viable services before we step into a whole nother program. Non-medical side of things has yet to receive the 1% increase that was already approved for state funding. So I'm asking with urgency to please approve that immediately, along with future budget considerations, and also the ARPA funding. The non-medical side has
Excuse
not
me,
received-
Anne, sorry. Your 3 minutes is up if you'd like to please summarize.
Sure, thank you. So I'm also asking that you please approve the ARPA funding before March 31st to help make us whole, but also so that the state of Connecticut does not lose out on its 10% federal match. I thank you for your time, and as always, appreciate the opportunity to speak on behalf of my loved ones, on behalf of your loved ones, and on behalf of my fellow agencies. Thank you. Any questions?
Thank you so much, Anne, for joining us today and for your testimony. Does anyone have any questions for Anne? All right, I don't see any. Thank you again.
Thank you.
Next up, Anna Dorgazi. Anna. All right. Number 42, Lori Kibbe, and I apologize if I have pronounced it wrong. Lori, are you with us? All right. Next, Sarah Buccino. And Sarah, I do think I saw you, number 43. Sarah, you're up. There you go.
Hi, can you hear me? Okay,
Yes.
great, thank you. Senator Moore, Representative Abercrombie, and distinguished members of the Human Services Committee. My name is Sarah Buccino. I am here to provide testimony on HB 5040. I'm the manager of social work services at Hartford Healthcare at Home, the largest home care agency in Connecticut. Over the last few years, especially during the pandemic, I have personally observed an increased need for social work services for all our patients, particularly those with Medicaid. Hartford Healthcare at Home provides skilled home-based nursing, therapy, and social work services to patients with complex medical, behavioral, and social needs throughout the entire state. Home health social workers are proficient at identifying and connecting high-risk patients with interventions to help them overcome barriers for better health outcomes. Due to limited resources, Medicaid patients are more likely to be impacted by social determinants of health and health disparities. Social determinants have a major impact on health outcomes, especially for individuals who are at or below the federal poverty limits. The COVID-19 pandemic has negatively affected many people's social determinants of health and mental health, and has created new barriers to connecting to community resources and assistance. To demonstrate healthcare quality and improved outcomes for vulnerable populations, it's imperative we realize that overall health, well-being, and quality of life are directly impacted by the conditions in which we live. Home health social workers have the advantage of observing patients in their home environment where they are the most comfortable, allowing them to complete the most comprehensive psychosocial assessments. Home health social workers are highly trained and through observation can skillfully identify unspoken needs, challenges, and social determinants that most likely would not have been uncovered in another setting. With this vantage point, home health social workers are also able to identify and timely report any signs of abuse, neglect, or exploitation, which can easily go unnoticed in other settings. Without being in the home, items like living conditions, family caregiver interactions, or food insecurities could be overlooked and left unaddressed. For this reason, home health social workers are often called upon by social workers in other settings requesting we make a home visit to assess what they cannot. Hartford Healthcare at Home social workers conduct an average of 71 visits per month to patients with Medicaid as their primary insurance, equating to approximately 850 unpaid visits in 2021, which is a 15% increase from 2020. This lack of reimbursement has limited our salary ranges for social workers, which further limits our potential hiring and retention practices. We are continually recruiting to fill empty positions to meet the needs of the service. Knowing that our Medicaid patients often have the most complex cases, it is unfortunate that Hartford Healthcare at Home and other home health providers have never had a reimbursement rate for social work visits. All other mental health professionals are reimbursed for providing social, emotional, and psychological services, yet home health social workers in Connecticut are not reimbursed for the same or similar services.
Excuse me, 3 minutes are over. Can you please summarize? Thank you.
Our Connecticut Medicaid residents deserve parity, and home health agencies deserve to be reimbursed for social work services. Please develop a competitive Medicaid home health care social work rate. Thank you for this opportunity and your time.
Thanks so much, Sarah, for your really comprehensive testimony. I see Representative Hughes has her hand up.
Thank you, Madam Chair, and thank you, Sarah, for this important aspect of reimbursement rates. Would you consider this more of an updating, given what during the pandemic, especially laying eyes on people in their homes has done for this entire service industry in terms of the traditional model of Medicaid reimbursement was obviously in the settings, in the hospital settings or in the long-term care. But now we're trying to update to where people are, and those complex Medicaid patients are in the home, right?
Yeah, we've certainly seen a large increase in care needs and complexity of our patients.
And what is the reimbursement rate that you're asking for?
I actually have not considered that, but at this point, I think any amount would be extremely helpful.
Okay, so Hartford Healthcare hasn't submitted a testimony to that yet.
I'm sorry?
Recommended. Hartford Healthcare hasn't submitted testimony about recommended reimbursement rate for home care social workers yet.
Not that I'm, but I'm not sure.
Okay, thanks. Thanks, Madam Chair.
Thank you.
Thank you, Rep. Hughes, for your questions. Anyone else have any questions for Sarah? All right, not seeing any others. Thank you so much for joining us today.
Thank you.
Next up, number 44, Michael Guile. Are you with us? Michael? All right. Next, number 45, Daniela Capetta. There you are. Hey, Daniela. I think you are still on mute.
Hi, sorry about that. I'm Daniela Capetta with Alara Caring, and I'm speaking on behalf of Bree Sanka, who was not able to join today. Senator Moore, Representative Abercrombie, and distinguished members of the Human Service Committee. My name is Bree Sanka, Regional Vice President for Behavioral Health at Alara Caring. I'm an RN with over 20 years experience, most of which has been in home health. I also serve as the board chair for Connecticut Healthcare at Home, the state association representing licensed and certified home health aid agencies throughout Connecticut. Alara Caring, formerly New England Home Care, is the largest provider of behavioral home health services in Connecticut, serving over 3,500 Medicaid beneficiaries in their homes and communities. The public health emergency that continues to impact our state only intensifies the need for home and community-based services for Connecticut's most vulnerable population. While many community support services have retreated during the pandemic, home health continues to provide valuable and necessary services to those with behavioral health conditions. Throughout most of the pandemic, a behavioral health nurse may have been the only human contact that many of these patients had, illustrating just how vital a role home health has played in the continuum of care. This has not been the exception over the last 2 years, but the rule. Behavioral home health services remain grossly underfunded. In fact, medication administration rates were cut by 15% in 2016, forcing many agencies to discontinue servicing Medicaid beneficiaries altogether. This drastic cut in reimbursement negatively competes with the state's ongoing initiative to maintain the behavioral health population in their homes rather than expensive institutional settings. The rate cut was predicted on the assumption that the medication administration in the community was simply that, ensuring a patient remains compliant with their medications. This is an overwhelming simplification of all that nurses do to safely maintain the behavioral health population in their home. HB 5277, the Ombudsman program for home health, is also in front of the committee. While we support the intent of this bill, funding an additional program before the foundation of home health is restored seems counterintuitive, especially when resources are dire. Inclusion of home health as part of the ARPA funding was appreciated and recognized. However, delays of the much needed one-time 5% FMAP payment continue with no definitive timeline for distribution. This payment would provide some much needed relief to those agencies that continue to provide services to Medicaid communities. Underfunding coupled with a public health crisis that has exacerbated an already strained system is a true threat to the Medicaid system. Restoring rates for behavioral health focused services delivered in a patient's home would be a major step towards ensuring that the infrastructure built to support the state's most vulnerable population remains intact and viable. Failure to do so could threaten access to care that all stakeholders have fought so hard to improve for decades. Please consider restoring the remaining 10.5% to the medication administration rate so that we can continue to improve the lives and outcomes of Connecticut's behavioral health population. Thank you.
Daniela, thank you so much for your testimony. Does anybody have any questions? All right, not seeing any. Thanks for joining us today. Next up is number 46, Kate Wall.
Good afternoon, everyone. I'd like to say good afternoon to Senator Moore, Representative Abercrombie, Senator Bertha, Representative Case, and all the distinguished members of the Human Services Committee. Thank you all for your service to the residents of the great state of Connecticut. My name is Kate Wall. I am the Berlin Town Clerk and President of Connecticut Town Clerks Association. And thank you for affording me the opportunity to submit support for House Bill 5232. And if I may, I'd like to give a shout out to Representative Abercrombie, who we are very lucky in the town of Berlin to have her as one of our representatives. So thank you very, very much, Kathy. House Bill 5232 will allow the town clerks to issue free dog licenses to owners of service dogs in their town. We are asking to change the effective date to upon passage. The town clerks start to issue dog licenses in June. By changing the effective date, all owners of service dogs will be able to benefit from this bill. So we are respectfully asking to have this bill effective earlier than later, so that during the month of June, we can issue the free licenses to any owners who come in with their service animals. We have submitted written testimony. If you have any questions about dog licenses, I'm happy to answer them.
Thank you so much, Kate, for being here. And I see Chairwoman Abercrombie has her hand up.
Thank you, Madam Chair. Good afternoon, Kate. So great to see you. Sorry, I'm on appropriations at the same time, so I'm not really good at trying to do both. I just want to take this opportunity to really say thank you to you and the association for reaching out and letting us know there was a little glitch in the timeline. We want to make sure that this bill, that everybody that has the opportunity to benefit from this legislation gets it. So I just want to say thank you for taking the time. And yes, we will definitely be changing the date. So thank you. Thank you, Madam Chair.
Thanks, Rep. Abercrombie.
Thank you, everybody.
Thanks, Kate. Anyone else have any questions for Kate? All right, not seeing any. Thank you so much for joining us today.
Thank you. Goodbye now.
Next up, number 47, Thomas Burr.
Yes, good afternoon, Representative Leeper and members of the Human Services Committee. My name is Thomas Burr, and I am the Community and Affiliate Relations Manager of the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. I am testifying today regarding support for SB number 196, an act prohibiting involuntary discharge from nursing homes and residential care homes to temporary or unstable housing. You should know that NAMI is dedicated to building better lives for those with lived experience with mental health illnesses and their families. NAMI Connecticut and its 9 local affiliates provide support groups and education programs for people with mental health conditions and their loved ones, and advocates for policies to improve the lives of people affected by mental health conditions. In regards to SB 196, as someone who has literally hosted over 100 NAMI family support groups during the past 2 years in this awful pandemic, I have heard too many stories of individuals who are due to be transitioned out of a medical or nursing home facility whose families cannot accept them, only to be informed by the facility staff that if the family does not take them, the facility will transport the person to the local homeless shelter. This situation leaves the family member with an impossible choice: accept someone into their homes they're incapable of providing care for, usually due to the complexities of their illness, or consent to their loved one being placed in a homeless shelter, or even at times literally discharged to the street. If you've ever been faced with this situation, you cannot imagine how stressful, gut-wrenching, and terrifying it is to be faced with such a choice. As a society, we can and must do better. Thankfully, it appears that the state of Connecticut, after finding itself in a mental health crisis, is prepared to do better. During the public hearings last week of both the Appropriations Committee and the Joint Children and Public Health Committees, NAMI Connecticut, along with many other individuals, providers, and advocates, at the request of these committees, detailed several items, many items that were needed above and beyond the items included in the governor's proposed budget and the Children's Omnibus Mental Health Bill. Please refer to my written testimony, which includes a link to my testimonies from these hearings, if you would like the details of what NAMI Connecticut is proposing. In essence, Having a fully funded and integrated coordinated mental health system in Connecticut will prevent discharge of extremely vulnerable people into a homeless shelter or the street. Until that day, we must declare loudly and publicly that this practice cannot stand. Thus, again, I urge you to pass SB 196. So thank you today for your time and attention. I'd be happy to answer any questions you might have.
Thank you so much, Thomas, for your passionate testimony and also just for all the work NAMI does on behalf of so many in Connecticut.
I appreciate that. Thank you.
I see Rep. Hughes has her hand up.
Thank you, Madam Chair, and thank you, Thomas, for really humanizing the face of this crisis and family members. We're talking family members of our community that get discharged into unsafe conditions, and it's part of the broken system. So I'm so glad that you can help us work together on addressing the continuum of care that we owe every resident in Connecticut. Thank you.
Yes, my pleasure. Thank you.
Thanks, Rep. Hughes. And I see Rep. Santiago, you have your hand up.
Thank you, Madam Chair. Thank you, Mr. Burr, for coming in. And, oh, I'm sorry, let me put my video on. There it goes. Thank you for coming in and testifying on that. And I agree with the request that is being done, especially because of the mental health issue. But do you have statistics or information as to what other states are doing, maybe in the New England area, that might be helpful to come up with ideas of what to do besides leaving them in nursing homes?
A lot of what other places are doing and what we're proposing actually is just beefing up a lot of the more transitional housing options. Especially this year, we're proposing that the state create or provide funding to create 5 peer-run respite transitional housing centers so that people do have a place to go that isn't necessarily a homeless shelter. I mean, it's also an upstream facility in as much as it'll hopefully prevent people from having to wind up in the ER who might be in psychiatric crisis and then get into the hospital and then maybe discharged to a nursing home and just that whole cycle. So it's a lot of the transitional housing where people don't necessarily need a high level of care that they would get in either a nursing home or inpatient hospitalization, but for people who aren't either have their own housing already or just need some level of care that isn't as intense again as a hospital or a nursing home.
Okay, so I was a shelter director at one time in Meriden, and we did have thank you, and we did have transitional housing on the second floor of the shelter in Meriden. So that was always full, and in order for that person to go into transitional housing, they could only be there for 2 years. And then, of course, the caseworkers would help them get apartments, etc. So you're looking at a program that has transitional housing that's already vacant, so that people that come from the hospital would have first dibs, or a criteria would be that they're going to be discharged and sent to a transitional housing. So you have to have that transitional housing already all set. So yeah, if you would send me what those proposals would be like, and maybe people that are interested in that, that would be helpful. Thank you. Thank you for your advocacy.
Yeah, I'd be happy to send you information on both peer-run respites as well as some of the housing solutions that have been put forth by the Reaching Home campaign. They've certainly been much closer to that whole thing than I necessarily have, and they've got some good proposals, and I can send you details on all of it.
That'll be great. Thank you. Thank you, Madam Chair.
Quite welcome.
Thanks, Representative Santiago. Any other questions for Thomas? All right, seeing none. Thank you so much for joining us today.
Thank you very much.
I see that number 41, Anna Dorgazi, is with us, and you are up. Thank you so much.
Great, thank you, and thank you for your flexibility. I got called in 2 committees at the exact same time, so thank you for
We are familiar
bringing me
with
back
that.
in line. Good afternoon, Senator Moore, Representative Abercrombie, ranking members. My name is Anna Dorgazi, and I am one of the Policy and Outreach Directors at AARP Connecticut. I appreciate the opportunity to speak with you today about our support for SB 195 and HB 5227. SB 195 enact increasing the minimum amount of assets that may be retained by the spouse of an institutionalized Medicaid recipient would support an individual's ability to live independently at home when their spouse enters a nursing home or other institution. When a married individual moves into a nursing home, his or her spouse who remains at home, also called the community spouse, must spend down their assets to a set amount before the institutionalized spouse can become eligible for Medicaid. When this happens, the community spouse loses his or her personal rainy day fund and is not as well equipped to address their own personal future needs that may arise. Allowing community spouses to keep more of these assets would provide them with the financial cushion they need to take care of themselves in the community and plan for their own future care and well-being. I think it's worth noting that in Connecticut, 1 in 7 nursing home residents are actually under the age of 65. Their community spouses may be part of this younger demographic as well, and they may have several decades of living in the community ahead of them that they need to save and prepare for. Allowing a community spouse to keep 100% of their assets up to $5,000 is appropriate, especially considering that Connecticut is a relatively high-cost state and also a state that has an above-average life expectancy. It's a sensible proposal, and we support its passage. We also strongly support HB 5227, which would establish the Community Ombudsman Program for home care. In recent years, Connecticut's made a lot of significant progress in providing long-term care recipients with more options for receiving services in the setting of their choosing. And many individuals have chosen to receive that care in home and community-based settings. AARP strongly supports and applauds efforts at the state and federal level to help more individuals return to or remain in their homes and communities to receive long-term care. And right now in Connecticut, we're serving 65% of our Medicaid long-term services and support recipients in these home and community-based settings. We believe that oversight efforts and supportive services like the Long-Term Care Ombudsman Program should reflect this ongoing focus on home and community-based services. The Long-Term Care Ombudsman Program currently works to improve the quality of life for residents of skilled nursing facilities, residential care homes, and managed residential care communities. In addition to responding to issues raised by individual long-term care recipients, the program is also able to identify systemic issues within these settings and advocate for policies to improve the quality of care. They provide critical support, resources, and advocacy that should be available to all long-term care recipients, including those who have chosen to receive their care in less restrictive settings. We love the Long-Term Care Ombudsman Program. We think it'd be very appropriate to make sure that more people are able to avail themselves of these services. And I thank you for the opportunity to express our support for both SB 195 and HB 5227. Thank you.
Thanks so much for your really comprehensive testimony, Anna. And thanks for coming back to us.
Thanks for having me back.
we all respect the juggle here. Does anyone have any questions for Anna? All right, I don't see any. Thank you so much.
Great, thank you.
Next up, we have number 48, Bill DeMaio. And I hope I got that right.
Yep, DeMaio, yep. Thank you so much, Madam Chair, and good afternoon to all the senators and representatives. Thanks for your hard work. I'm in full support of the service animal bill that's in front of you in the HR 5232 bill. I'm blind, have a Fidelco guide dog named Lyric. I am the Parks and Recreation Superintendent in Newington. I'm the president of the ADA Connecticut Coalition. I'm certified nationally with the ADA coordinators program, and I'm also on the State Rehabilitation Council. I speak here before you with no money to ask for the state of Connecticut. Imagine that. Just a bill that's going to clean up the language of a bill that was written back in the 1930s. This service animal bill is very important for us. It's our third time bringing it in front of the legislators. And we've modernized all the language so that it's up to date and goes in mirrors the ADA that was a federal law put into place back July 26th in 1990. So we're hoping, and I kudos to Representative Kathy Abercrombie. She's just been fabulous in regards to working with us to try to make sure everything is up to snuff, and that people with disabilities, both mental and physical disabilities, so not just blindness, hearing impaired, mobility, but also people that have disabilities that use service animals for anxiety and depression and seizures, all that. You have an opportunity to help all the people with disabilities that use service animals in the state of Connecticut. And we're really encouraging you to do that. It's going to be a fabulous thing for all of us, and it gives us freedom and independence. It gives us opportunities to go into public spaces that everyone else gets the right to go into, with confidence and with independence. So I strongly urge you to vote yes, and ask all your friends on both in the Senate and the House to vote yes for this service animal bill. We would really appreciate it. You'll make a bunch of people in the state of Connecticut that have disabilities much more happier and more independent and free. So please consider that. And if you have any questions, please offline, you can call me at any time in my office or on my cell phone. And I appreciate everything that you've done for us.
Thank you so much, Bill, for that really thorough and passionate testimony. Not asking for money and being able to deliver on freedom and independence seems like a pretty good ask. So thanks for that. And I see Representative Case has his hand up.
Hey, Bill, thank you for coming out. And, not only will this bill clarify things for you guys, but it will clarify things for everybody, because there are so many questions and concerns out there of what dogs are certified and where. And having ECAT in my district, where we train dogs up here, is just huge. And I just want to thank you for your advocacy. And, it's good to see you.
It's good to see you, Senator. It's great to have you on board.
Thanks, Representative Case. Thank you so much, Bill. Does anyone else have any questions? I don't see any others. Thank you again. Have a great day.
Yep, thanks for your time.
Number 49, Stan Sobey, you're up.
Thank you, Madam Chair. Good afternoon to you and Senator Moore, Representative Abercrombie, Representative Case, and members of the Human Services Committee. I'm Stan Sobey, Vice President for Public Policy and External Affairs at Oak Hill. Founded by Emily Wells Foster in 1893, Oak Hill is the largest purchase of service provider in the state and a leader in providing quality community-based programs and services for people with disabilities. We currently serve Connecticut citizens in 77 towns. Oak Hill normally employs 1,700 professionals to meet the changing needs of close to 30,000 people a year with disabilities, but we currently have 200 plus vacancies. I'd like to thank you for the opportunity to provide testimony in support of House Bill 5225. And while mindful of the Commissioner Gifford's testimony earlier today, allowing for clawbacks just perpetuates a spend it or lose it mentality in the system, which is not how anybody should want it to be the way things work. During this pandemic period, we've had to close some programs temporarily because of unfilled residential vacancies. Now that's resulted in some savings from combining staffing and from some facility cost reductions. However, those savings were spent in overtime costs to fill vacancies, on recruitment efforts, and on adding technology that would help support program services, and in the hopes that it would all be recognized at year end. Over a number of sessions, providers have appeared before this committee to stress the importance of flexibility in funding for nonprofits. One of the lessons learned or maybe relearned in this pandemic has been the need for flexibility and creativity. And as the Department of Developmental Services looks to implement a new 5-year plan, its ambitious and laudatory goals will be difficult to achieve if the nonprofit provider community does not have the fiscal flexibility to pivot from existing housing and service models to new service designs. And while the public health emergency may have receded for some, there is still a heightened sense of urgency in the provider community, which includes the need for the state to end the practice of clawing back surplus funding. We hope that with the ongoing support from this committee and the legislature, This is the year that the innovation program will finally be implemented. Thank you.
Thank you so much, Stan, for your testimony. Does anyone have any questions for Stan? All right, not seeing any. I really appreciate you joining us today.
Thank you, Madam Chair.
Next up, we have number 50, Jean Mills Aranha. I'm sure I just butchered that and I'm so sorry.
It's no problem. Thank you very much. My name is Jean Mills Arana, and I'm speaking in support of SB 196, an act prohibiting involuntary discharge from nursing homes and residential care homes to temporary unstable housing. I'm the managing attorney of the Stamford Office of Connecticut Legal Services, where I practice elder law, and I served on the Governor's Nursing Home and Assisted Living Oversight Working Group. I'd like to clarify a comment made earlier by Rep. Abercrombie that this bill focuses mainly on residential care homes, because in fact, in my practice, we see many more cases coming out of our nursing homes. I'd also like to mention that while programs like Money Follows the Person and CHESS are helpful, not all residents of these facilities meet the requirements for them, particularly for CHESS, which requires a history of homelessness that residents may not have. Also, while the expansion of the long-term care ombudsman program to community settings is a good idea, the long-term care ombudsman already has jurisdiction over nursing homes and RCHs. So the expansion of the jurisdiction will not directly address the problem of discharges to homeless shelters and other stable housing. And we agree in principle with many of the issues raised by Matt Barrett, but we feel that his proposed substitute language may raise more questions than it answers. Everyone seems to agree in principle that it's not appropriate to involuntarily discharge nursing home and RCH residents to homeless shelters or unstable housing. I give several examples of this in my written testimony, and I hope that you'll read it. But I'd like to turn here to what can be done to prevent it. The answer is that nursing homes and residential care home industries must be more proactive in planning safe and appropriate discharges. If a resident is improving in health so that the resident will no longer need nursing home level of care, the home should be working early on to find and facilitate an appropriate discharge, rather than effectively discharging to the street at the last minute. Facilities should have adequate social work staff to work on these issues from the time of admission onward. And legislation passed last session recognized the need for greater facility staffing and increased the required number of social workers in nursing homes. Where a resident exhibits behaviors perceived as difficult, the nursing facility has an obligation to do person-centered care planning to address those behaviors before it gets to the point of a discharge. And RCHs are required by law to assist the resident they are discharging to find appropriate placement. These facilities should not simply be able to dump a resident into a homeless shelter or other temporary unstable housing. There are resources such as police, mobile crisis teams, or protective services for the elderly able to respond to true and unexpected emergencies. But otherwise, facilities should be doing appropriate planning for future needs of their residents. Connecticut can do better than allowing some of its most vulnerable citizens to be charged to unsafe and temporary housing or homeless shelters. We ask you to please support Senate Bill 196. Thank you for considering my comments on this important legislation. I'd be happy to answer any questions that you have.
Thank you so much, Jean, for your testimony today. Does anyone have any questions? All right, I don't see any, but I really appreciate it. And your written testimony will certainly be read. So thank you
very
for
much.
submitting that.
Thank you. I appreciate it.
Next up, number 51, Heather Gates. Thank you for joining us.
Good afternoon. Thank you. I appreciate the opportunity to testify before you in support of House Bill 5225. My name is Heather Gates, and I'm the president and CEO of Community Health Resources. We are a large and comprehensive provider of mental health and substance use treatment and support, housing, foster care, and primary care services. We hold contracts with DEMIS, DCF, DOH, DOC, DSS, and CSSD, employing over 900 staff and serving countless numbers throughout Connecticut. Over the course of the last 2 years, during one of the worst periods of time ever to be providing services, we continued on meeting our mission to serve those most in need. This year in particular has been brutal with the staffing shortages and the need to increase salaries for all of our staff. We have a terrible dilemma we are accruing paybacks to the state while at the same time we cannot increase salaries because we cannot count on being allowed to use this funding consistently because the state takes it back at the end of every fiscal year. Right now, we have a deficit of $425,000, and we're accruing $400,000 to pay back to the state. This is quite frankly ridiculous. And we're pretty tired of the antiquated contracting rules related to the services we deliver. The current structure leaves us financially fragile and undercapitalized year after year after year. This payback represents a 0.5% of our total budget. It is a tiny amount of money, and we can use it to pay down mortgages, offset our deficit, offset the cost of PPEs and testing, distribute more hazard pay, and countless other uses, including helping with our financial stability. So I would ask you, does the state really need this money back when our staff and our services are in such desperate need, given the serious lack of funding we've received for so many years? So please pass this bill. This would be I think the fourth attempt to get the administration to finally honor what the legislature has asked them to do. So thank you very much. Happy to answer questions.
Heather, thank you so much for your testimony, and thank you so much for all the work you continue to do under just unimaginably difficult circumstances the past 2 years. And really, it applies to so many people who have commented today, but I just want to make sure to make that comment and recognize that Connecticut's most vulnerable residents continue to be served because of work that you all do. So thank you. Does anyone have any questions or comments? All right, not seeing anything. Thank you again for your testimony today. Number 52, Deb Polan, thank you for joining us.
Good afternoon, everyone. My name is Deb Polan, and I am the Executive Director of the Connecticut Association for Community Action. We're the state association that works with the 9 community action agencies in the state who serve people in all of your towns, about 200,000 low-income people across the state every year. The community action agencies provide a variety of different kinds of services to low-income people, including case management, enrollment into energy assistance, enrollment into SNAP. Many do childcare, Meals on Wheels, asset development, financial literacy, and a variety of other programs. We have submitted written testimony today, and I just wanted to provide some brief comments on 2 bills that are before you. The first is House Bill 5040, the governor's budget implementer, and I'd like to comment on sections 2 and 3, which clarify a drafting error that was made last year regarding community health workers in community action agencies. So we want to thank the legislature for putting together this program to enhance the capacity of community action agencies to utilize community health workers, which I know all of you support. There was a drafting error in the budget implementer last year, which restricts the amount of the funds that can actually be released. Although $6 million was allocated, $3 million per year, only $270,000 is available for release right now because of this error. And so would really like to see this get fixed. We're appreciative that the governor put this in his implementer and would actually like to see this get moved forward in a bill early this session, because the earlier the money is released, the sooner it can be used towards improving the capacity for community health workers at community action agencies. And we do have about 100 community health workers already working at community action agencies, providing lots of different resources around quarantine and isolation, connecting people to health services, et cetera. The second bill I'd like to comment on is House Bill 5231, and this is the bill around senior nutrition. 5 of our community action agencies provide Meals on Wheels, and this, as I know you know, is an extremely valuable service that helps older adults stay in the communities as they age and get nutritious food and contributes to a better overall well-being. To be transparent, we're also asking for a rate increase for Meals on Wheels, but we do also support the study that is contained in this bill. This is a really important program, only going to become more important over time. And we've seen costs go up for groceries, gas, paper products, labor, and all of those things. So it's time to enhance the rates for this program among so many others that serve people in need in our state. I want to thank you for paying attention today, to everybody who's testified before you, and thank you as always for your service to our state.
Thanks so much, Deb. And thank you. I think the thanks I expressed before just as relevant to you. And we certainly all have members of our community that benefit from the work that you do. So thank you. I see Chairwoman Abercrombie has her hand up.
Thank you, Madam Chair. Hi, Deb. Good afternoon. So one question and one comment. So on the comment, just so that my colleagues understand what happened in the budget last year. So Deb's right. We put in $6 million to go through the CAAs, which are the community action agencies, in order for them to be able to hire more and train community health workers. The way the language was written, it said 30,000 per site, when it should have said 30,000 per person. So that's why the money, only part of the money was released, and that's why you see this this language here now, so that we can make sure that the money gets out, because we know it's so important. So you know, there was a lot of language last year, and this just happens to be one of them that, you know, came out not exactly what the intention was. So just so everybody knows, that's how that happened. Then the second thing is for the Meals on Wheels. Deb, could you do me a favor and just send me a quick email when you get a chance with a phone number to call you? There's a lot of money that's coming through disability, aging and disabilities for meals. And so what's become challenging is, right, we have a lot of people doing Meals on Wheels. So if you're part of a waiver program, you're automatically getting these dollars increased. If you're, for lack of a better word, I'm going to call it an independent Meals on Wheels, which a lot of them are, you're not getting these increases. So I really want to talk to you about how we can make sure that those dollars are spread out equally amongst all the providers, because I think Representative Cook has been really working hard on this issue over the last few years, and that's what her intent is on the data collection, right? To understand who's getting these increases, because every time we talk about increases, right, the agencies say, well, the providers got it, but they're not saying that it's only certain providers. So we've been able to drill down to try and figure out the difference, but I want to make sure that all of the providers, and we're working with Joel, who was on the call a while ago, on the Zoom, around this issue also. So just send me a quick email and whatever number, that would be great. Thank you, Madam Chair.
That. This is one of those programs that is more complicated than it feels like it should be. And it does make it hard to figure out where the money's coming from and where it's actually going. So I appreciate all the efforts.
Thanks, Representative Abercrombie. Thank you so much, Deb. Does anyone else have any questions? All right, I don't see any. Thanks so much for your testimony and joining us today.
Thank you.
Next up, number 53, Mag Morelli.
Thank you. Good afternoon. My name is Mag Morelli, and I'm the president of Leading Age Connecticut, a membership association of not-for-profit and mission-driven organizations representing the entire field of aging services and senior housing, including not-for-profit nursing homes and residential care homes. I'm pleased to be here today. We've submitted testimony on two of the bills before you, and I just will briefly summarize the testimony. First, on House Bill 5040, an act concerning the governor's budget recommendations for human services. We provided extensive testimony to the Appropriations Committee on all of the budget adjustments related to DSS, and we provided a link in our testimony to that for the committee's information. But regarding the bill before you today, we want to speak to Section 4. Leading Age Connecticut spoke to you last year about the deficiencies and inequities that exist in the current nursing home rate system, caused by years of disregarding the statutory rate formula. The inequities have disadvantaged many high-quality nursing homes, including the nonprofit nursing homes we represent. The legislature responded to our concerns and placed $10 million in the biennial budget for nursing home facility support to be used for one-time grants to homes that had significant gaps between their calculated rates and their paid rates. And we really thank you for that. Subsequently, in developing the acuity-based rate formula, which will go into effect on July 1, The administration determined that this inequity in the existing rate should be permanently addressed in the new rate system. And as a result, they're proposing to invest additional funding so that the rates can be rebased. The true rebasing will recognize the allowable costs and increase the rates of nursing homes that have continuously invested in their physical plants, services, and workforce. The rebasing of the rates will require an additional investment of state and federal dollars over the 3-year phase-in of the acuity rate system. So in the meantime, the $10 million that was included in the budget for nursing facility support is proposed to be used to fund a 10% temporary rate increase for the month of June, something that is urgently needed and greatly appreciated. And that's the adjustment that you see in section 4 of the bill before you. So thank you for this opportunity to thank you for all that you did to support us on this issue and to advocate for the high quality nursing homes in the state. Just briefly on Senate Bill 196, you've heard a lot of testimony today, and I support the testimony of Matt Barrett. Regarding nursing homes, there are very comprehensive state and federal statutes governing transfer and discharge of residents that encompass many scenarios and conditions, and including the involuntary situations. Residential care homes also must address the health and safety of the resident when initiating an involuntary transfer or discharge. And in both situations, the resident has a right to appeal. But what you've heard today is this is a much bigger picture. It's not as easy as just prohibiting a discharge to an involuntary discharge to a homeless shelter. What we need are more resources and more assistance in helping individuals find stable housing. The nursing home is not the appropriate housing for someone who's in need of stable housing. But we want to be able to offer short-term rehab. We want to be able to provide the nursing home care when needed. And then there is a need for some assistance in transitioning people back to a more stable housing site. So we're happy to work with everyone involved in this. I've spoken to the Ombudsman and others on the issue. And we are here to help to solve the bigger picture problem that this bill is addressing. So thank you. I'd be happy to answer any questions.
Thanks so much for your comprehensive testimony, Meg. Does anyone have any questions? All right, I don't see any, but we will certainly be reading your submitted written testimony. Thank you for that.
Thank you.
Next up, number 54, Chris McNabo.
Good afternoon, Senator Moore, Representative Lepper, Representative Abercrombie, Representative Case, and members of the Human Services Committee. I'm Chris McNabo, founder and CEO of Horizon, celebrating our 43rd year supporting people with developmental disabilities statewide. I'm here today in support of HB 5225, which you've heard from many others about, including Ben Shaken, so expertly outlined. Hopefully, this third time will be the charm. The legislature already passed 3 laws since 2017 to eliminate the practice of clawbacks. State contracting policies continue to mandate that nonprofit savings must be returned to the state. Now, the rainy day fund is fully funded with $3.1 billion. The pension liability has been paid down by $1.6 billion, and more payments will be made. Our state continues to experience very strong revenue streams, and clawbacks are still happening. We're experiencing a staffing catastrophe, as you've heard today. Retention and recruitment costs, vehicle expenses, energy costs, computer, technology, cybersecurity, COVID mitigation, including the cost to rent additional spaces, are unprecedented. And nursing costs are breaking the bank, causing us to eliminate providing those services to some of our folks. In a world where Target is offering a $24 an hour starting wage in some areas, we're sunk. Being able to retain unspent funds would mean we'd reinvest in our most precious commodity, our staff. We'd invest in our future by providing training and mentored experiences to our future leaders, provide our staff assistance, counseling, and therapy for the myriad of mental health issues caused by the pandemic. Acknowledge our essential employees as they were deemed by this governor by offering end of pandemic PTO so they can recuperate. Invest in technology staff could use with individuals they support for greater independence. Purchase buildings, equipment, and other large capital items like solar that lower our costs, create professional environments, and improve quality. And have the ability to think and plan beyond 1 year. Banks laugh at us when we ask for lines of credit because we operate so close to the bone, often with lags in receiving payments for our contracted services. Connecticut is an outlier in clawing back money from nonprofits. Our colleagues in nearly every other state are able to invest in quality improvements and sustainability. CMS recognizes this and allows this retention. Allowing revenue retention will be one step of many to undo the chronic underfunding of more than a decade. Thank you.
Chris, thank you so much for your passionate testimony. I see Rep. Hughes has her hand up.
Thank you, Madam Chair, and thank you, Chris, for your advocacy. I really see this as an updating of the way that we, pay the nonprofit system for care. You especially talked about the lags in payments that you receive and how this is very different than other, say, nonprofit businesses that have a fee for service at the time of service. And I think that's important to elevate as we attempt to correct a wrong, really, a penalty for nonprofit service providers to the most vulnerable. And also when you talk about solar, that's a whole other area that you're unable to keep up with your counterparts and engage in investment in renewable energy and lowering operating costs because you just don't have that buffer. So I'm hoping we can pass this early session and get you back on your feet.
Thank you very much, Representative Hughes.
Thanks, Rep. Hughes. Any other questions? All right, thanks so much for joining us today, Chris.
Thank you.
Next up, number 55, Sabrina Trochi.
Good afternoon, Madam Chair and distinguished members of the Human Service Committee. My name is Sabrina Trochi, and I'm the President CEO of Wheeler. Wheeler provides a comprehensive continuum of integrated primary care, mental health, substance abuse recovery, community justice, special education, child welfare, early childhood, and prevention wellness services to over 50,000 children, families, and adults across many communities in Connecticut. We work with some of the most vulnerable and medically underserved populations in the state. I thank you for the opportunity to provide testimony in support of House Bill 5225, which would prohibit the practice of state agencies, including the judicial branch, from clawing back surplus funds from nonprofits at the end of the fiscal year. This would allow nonprofits to retain savings, reinvest them in the service delivery system, reinvest them in our workforce, reinvest them in addressing gaps in care. Despite legislators having already passed 3 laws to eliminate the practice of clawbacks, including Public Act 21-2, which was enacted in 2021 and set forth implementation of the Innovation Incentive Program across state agencies, beginning in this fiscal year, 2022, we are close to ending the 3rd quarter of this fiscal year and have yet to receive any information from state agencies on how they will adhere to and implement the Innovation Incentive Program. This year, more than ever, we have a heightened sense of urgency to retain the surplus funding. Wheeler, and as you've heard from many of my fellow nonprofit health and human service organization providers, are facing unprecedented workforce challenges. In addition to competing with state agencies, hospital systems, we're now competing with Walmart, Amazon, Target that require no specialized training, are paying more, and can even incentivize staff to go to them. Our current vacancy rate ranges from 14 to 25%, depending on the program and the service. It is absolutely unsustainable. We've needed to implement staffing incentives, sign-on bonuses, and other strategies to keep our program staffed and to keep our doors open. At the same time, we're seeing a significant increase in patients presenting for care. In 2021, we saw over a 20% increase across our outpatient health and wellness centers as compared to 2019. Without the ability to retain these funds beginning in this fiscal year, as we expected with the enactment of Public Act 21-2, coupled with the overall underfunding of community nonprofits and the workforce shortage crisis, we risk further destabilizing our state's community service delivery system at the same time that we're facing unprecedented behavioral health challenges. I thank you for this opportunity to be heard, and I welcome any questions.
Thank you so much, Sabrina, for your testimony. I see Rep. Abercrombie has her hand up.
Thank you, Madam Chair. Sabrina, I just wanted to publicly apologize to you. I know you sent me a couple of emails, and I'm so sorry I have not been able to get back to you, especially because I know that we have a issue going on with the closure of therapeutic group homes through DCF, but I want you to know that we are working on it through the subcommittee with DCF, and I will definitely give you a call. I just wanted you to know that I wasn't ignoring you. It's just, these Zooms are a lot harder than people think, you know, when you're trying to do 2-3 committees at once. So thank you for your testimony and thank you for being here.
I appreciate that. Thank you.
Thanks, Rep. Abercrombie. Does anyone else have any questions? All right. Thank you so much for joining us.
Thank you.
Next up, number 56, Jay Katz.
Hi, good afternoon. Senator Moore, Representative Abercrombie, Senator Berthel, Representative Case, and members of the Human Services Committee. Thank you for the opportunity to offer testimony regarding SB number 196, an act to prohibit involuntary discharges from nursing homes and residential care homes to temporary or unstable housing. Just want to mention our board chair. On behalf of our board chair, former Representative Bill Dyson sends his regards, and he hopes that you support us in opposing this bill. My name is Jay Katz. I am an RCH operator in the city of New Haven. I know that Karch had submitted a testimony. I just wanted to sort of give my perception of our process, or our perception of our process when we do initiate an involuntary discharge. Leeway's involuntary discharge process starts after a series of unsuccessful interventions to change a behavior that presents a danger to the rest of the residents living in our facility. Our process includes a discharge plan to a safe location that can accommodate the physical and mental conditions of the resident. We present discharge options to the resident, ombudsman, and to the Department of Public Health for approval. The usual destination for discharge is another RCH. The resident can appeal the discharge, which we assist them with. In collaboration with the regional ombudsman, we suggest the resident obtains legal counsel. Our RCH supervisor offers to coordinate that service. Our staff, from the time we issue the involuntary discharge, works with the resident to transition them to their next location. The success of the process is dependent on the resident's cooperation. Many times, the resident will forfeit placement opportunities waiting for their appeal hearing. After the appeal hearing, the resident will be permitted to stay or have a specific date on when they must exit the facility. If the ruling upholds the discharge, we urgently apply and reapply to facilities in the area and then expand our search to larger areas depending on bed availability and resident cooperation. Once we secure a bed and coordinate care for that individual, the individual can elect to take the bed or use the 211 system. Most of our residents come from the homeless system and enter RCH after their physical conditions that require a skilled nursing stay resolved. Because of the scarce supply and affordable housing and resources limitations at Leeway, it is extremely challenging to find housing placement during a short-term skilled nursing stay. These residents reluctantly transfer to our RCH. While living on our RCH, we offer our residents a HOPWA case manager to assist them in obtaining community placement and skill building to ensure success in the most independent environment possible. Some residents become discouraged with the length of time they must wait for an available apartment to move to. Occasionally, these disappointed residents behave destructively and present a risk to other residents. When this behavior becomes a threat to the well-being of our community, we begin the involuntary discharge process. Some of our residents have trusted their previous experience in the homeless system and have elected not to take advantage of what we have suggested. They take their chances that immediate resources will become available post-discharge through the 211 system. Most of the time, the system is successful in finding resources for these residents. And in the event that they are not, we continue to follow up with the resident in hopes that they would accept the plan we've created for them. Leeway's resources are limited in what we can provide, and services are restricted to the residents because of where they live. Leeway wants to be a good partner to the community and the people we serve. I don't know if provider restrictions will result in the best care for our community.
Excuse me, 3 minutes are over. Can you please summarize?
I'm all set. Thank you.
Thank you so much, Jay. I appreciate your comprehensive testimony, and I think we recognize this is definitely a complex issue. And I see Rep. Abercrombie has her hand up.
Thank you, Madam Chair. Good afternoon, Jay. Thank you so much for being in here. And so I just have to publicly say that I am not against RCHs. I'm not against the work that you do. I just think that we have a problem with the system and we're trying to figure out a solution. And I was on a call with some of your other providers that are RCHs a couple of weeks ago, and we're trying to work through how do we get this language correct. But I just have to say publicly that there is a problem, and I get it that, you're not clinicians and that sometimes things happen in your facilities and you feel that it's not an appropriate setting for an individual. But at the same time, no individual should have to go to a homeless shelter. So I think that there's a compromise that we can find. I think that there's also a lot of work going on right now with DSS as far as where do RCHs fit in our continuous of care. I know that we've had a problem with the Medicaid reimbursement. I think that there's going to be, if you haven't had a conversation yet, shortly, there's going to be a conversation with RCHs about the Medicaid billing and moving that out a couple of years, and then also looking at your facilities overall and looking at other services that you could provide, looking at a level of need and trying to really ramp up RCHs. So, I just want you to know publicly, it's not personal. There is a problem in the system and we're just trying to figure it out. So thank you for being here and thank you for your testimony. Thank you, Madam Chair.
Thanks, Rep. Abercrombie. Does anyone else have any questions for Jay? All right, I don't see any. Thank you so much for joining us today.
Thank you.
Next up, number 57, Tina Yeats.
Good afternoon. Good afternoon, Representative Leeper, Representative Abercrombie, and members of the panel. Thank you for hearing testimony today from those of us regarding an act prohibiting involuntary discharges from nursing homes and residential care homes to temporary or unstable housing. My name is Tina Yeats, and I'm president of the Connecticut Association of Residential Care Homes, also known as CARCH. I'm also the administrator of the Eliza Huntington Home in Norwich. I'm testifying today on behalf of CARCH and our members to raise similar concerns about Senate Bill 196 and prohibiting the involuntary discharges from nursing homes and RCHs to temporary or unstable housing. Let me first begin by saying no home ever wants to involuntary discharge a resident. That's why we support the intent of the legislation in ensuring that no resident is placed in unstable housing. However, there are several reasons for why this may occur in either a voluntary or involuntary discharge. First, some residents are referred to residential care homes from those homeless shelters. So when they either voluntary or involuntary are looking to be discharged, that shelter may always be their first choice for that resident. Additionally, homeless shelters often have access to a number of services, including other affordable housing options and potential resources that individuals living in our residential care homes do not have access to. So there are supportive and temporary housing referrals that they know are going to be available to them. Discharges, both involuntary and voluntary, are challenged for the residents and the homes due to the difficulty in finding appropriate settings for them. As many committee members know, residential care homes range in size from small homes, with some of us with less than 10 beds to over 50 beds. Residents in most facilities are individuals who have behavioral health diagnosis. Residential care homes offer that home-like environment with the staff that provide their care, med administration, and food and shelter. It's a non-medical model, but it allows them to live independently with others in their community. Unfortunately, there are instances where when they need to be discharged, whether it's creating an unsafe environment in the home, threatening other residents, violence, continual smoking, fires from smoking inside, and their own health has deteriorated. In these instances, the staff tries to work with the resident and if there's a conservator available, also work with them to find suitable residents, but can be a challenge when they're not cooperating and they don't want that to be their resolution. There are times when the conservators themselves present the hurdles in finding appropriate housing. So the legislation, while well-intended, may put the residential care home in a challenging and almost impossible situation for helping these residents. Under the current statute, RCHs are already responsible for assisting the resident finding appropriate placements, including a plan prepared by the facility, which indicates the resident's individual needs and that they shall accompany that resident.
Excuse me, your 3 minutes are over. Can you please summarize?
Thank you very much. We are concerned about the intent, the overall intent with this legislation, but appreciate the opportunity to offer testimony today and hope that you will consider the above amendment.
Thank you so much, Tina, for your testimony. Does anyone have any questions for Tina? All right, I really appreciate you joining us today. Thank you.
Thank you.
Next up, number 58. Sorry about that. Parisa Charmichi Goodwin.
Thank you, Representative, and thank you, members of the Human Services Committee. My name is Parisa Charmichi Goodwin, and I'm testifying on behalf of the Connecticut Oral Health Initiative in my role as the Executive Director. COHI is a statewide nonprofit that advocates for access to quality oral health services for all Connecticut residents, and we are testifying with regard to House Bill 5040, specifically the proposed dental reimbursement rate increases. We strongly support the governor's proposed 25% increase in the adult dental reimbursement rates and the additional increase in the endodontic rates for adults. We also respectfully ask you to consider a larger increase for the adult dental rates to bring them to parity with the child rates. The adult dental rates are currently almost half of the child rates, and they're really far too low. We hear from adults on Medicaid all the time about their difficulty accessing dental care. For example, access to root canals has been a particular problem. The average wait time, if you're on Medicaid in Connecticut, is 4 months, which is far too long to be living in pain like that. And it's also too long for the tooth to be salvageable. So 8 times out of 10, according to safety net providers in Connecticut, they end up getting extractions because they can't actually get the root canal. There's only one endodontist in Connecticut who right now is accepting Husky. Dentists are very reluctant to accept Husky because the reimbursement rates are so low for the adult patients. They have not been raised in 14 years, so they're very outdated rates. Costs go up naturally, and in the pandemic, there's been a surge on PPE. I believe the cost of masks has about doubled and gloves has about tripled. So sometimes the fees don't even cover the material costs. It's imperative that adults have access to care in order to prevent the worst of oral health outcomes, like I've already mentioned, severe pain, infection, tooth loss. And those infections can travel to the heart or to the brain, cause serious injuries and sometimes death. So the need for a strong safety net is already here, and it's also growing. There are over 500,000 adults on Husky in the state of Connecticut. And an estimated 39,000 people will be eligible for Covered Connecticut, which includes Husky Dental. which we're frankly ecstatic about. I am so glad that more people will have access to dental coverage, but coverage is not enough. It's imperative that people are able to use that coverage in order to get the services that they need. So this is fundamentally a supply and demand issue. There are not enough providers accepting adults on Husky to meet the need. And dentists have been very clear that the reason is low reimbursement. We've been conducting a Medicaid gap analysis where we've been doing interviews and focus groups of both adults on Husky and dental providers. And this has been a really, really constant drumbeat from both sides of that. I want to talk a little bit about the financing. While a rate increase will require an additional investment of state dollars, the federal share should cover the majority of the cost. State spending on adult dental Medicaid is eligible for federal reimbursement to states. The federal share is 50% or more, depending on the population and part of the program. So Husky A, B, C, or D. For the expansion population, the federal share is 90%. So what we really don't want is for federal dollars to be left on the table when that money could improve access to care here in Connecticut.
Excuse me, 3 minutes are over. Can you please summarize?
Sure. Yes,
Thank
yes.
you.
I'll just close out by saying that oral health is also a good investment because it impacts, like I said, so many other parts of the body. And it's really an upstream tool. So again, we're supportive, but we would like to see more. We know that a larger increase would have a larger impact on access to care. Thank you so much for your time.
Thanks so much, Parisa, for that really comprehensive testimony. And I'm glad that you were here to speak to this particular dental issue. I've been hearing this from my own dentist, actually. So thank you. I see Rep. Abercrombie with her hand up.
Thank you, Madam Chair. So, Parisa, one thing you guys know about me is I'm pretty frank about things. And I have to tell you, I'm going to say it out loud. Shame on the dentist, because I can't think of a provider out there that wouldn't be happy with a 25% increase. Nobody has gotten a 25% increase. You guys are in line with every other provider out there that has not gotten an increase for 10 years. And here you're getting a 25% increase plus more, and they're saying it's not enough. So I just have to say publicly, especially because I'm on appropriations, shame on you guys, really, shame on you guys. So thank you for being here, but I'm really disappointed in your testimony.
I completely understand. I do want to be clear that COHI is an advocacy organization. We are not dental providers. And I do completely understand your frustration. I do completely understand.
Thanks, Rep. Abercrombie. Representative Dathan, I see you have your hand up.
Thank you very much, Madam Chair, and thank you for your testimony, Parisa. Just a quick question in terms of where the rates are for Husky patients compared to other states. Do you have any metrics that can provide some sort of guidance on us? And apologies if I missed it. I'm bouncing between two different public hearings right now.
Yes, no worries at all. I believe that I did footnote a resource comparing all of the states in my testimony. We are, for the adult population, we are one of the lowest. I think we're the second to lowest in the country. So the average is about 37.5 cents on the dollar compared to average insurance for dental. So it's extremely low. Whereas our child rates are about 67 cents on the dollar, which is considered very reasonable and is kind of an expected number for public insurance. So the 25% increase would bring us to about 46.5 cents on the dollar, which is still quite low. And I do hate to say it, but there is some really good research on what dental rate increases can do for dental access. And what we see is that there is a positive association, but the increase needs to be quite large for there to be that increase. So for example, when we did increase the child rates in 2008 and that change took effect in 2009, it was a dramatic increase and that did bring on a lot more providers for the child network. So I understand, I'm completely in agreement that 25% is a wonderful feat and I'm very grateful for it. I think that it will help some people, but I know that it is the time to ask, and I think that we need to ask because I know that It won't go as far as we would like it to go. COHI is really concerned with, the fact that only 1 out of 3 adults on Husky are seeing a dentist. And actually this past year of data, it was 1 in 4 adults on Husky saw a dentist. So that's why we're asking for more if it's possible.
So because I'm also sit on the insurance committee, if you're comparing Medicaid rates to fully insured rates for your analysis, should we also be considering fully, and I know this is out of the cognizance of this committee, but I'm just trying to make sure that we're comparing apples to apples. So I have noticed in the last couple of years that I have several dentists that I have seen that, is costing more out of pocket money for me as a insured with. So I'm just wondering if there is some sort of market trends that is making it more difficult for dentists to get reimbursement on insurance as well as and I'm just wondering if that's maybe part of this dynamic. And apologies, Madam Chair, if that's going outside of the scope, but I'm just trying to get a full understanding of how our Husky patients, because I agree with you, so many of the preventative procedures that dentists do detect, more grave things, and catching these things early can promote better outcomes.
Yeah, thank you for that question. What I've been hearing from providers is really the PPE surge has been particularly difficult. So that's, I think, the biggest recent cost that has just been skyrocketing. So they're spending an average of $16 per patient per encounter on the PPE. So when you look at, a cleaning is reimbursed for an adult on Husky, I think maybe $23 or $24. If you look at your own bill, if you go to the dentist, I'm sure that your insurance is reimbursing over $100 for that visit. So there is a very dramatic difference. The average pay for a hygienist is about $45 an hour. So if the hygienist is providing that care to you and they're spending that much on the PPE, think of that as almost 60 bucks. And then they're being reimbursed $24. So it's really no question when you look at the financing, it's frankly not surprising that a lot of providers are not accepting a lot of adults on Husky, although it is heartbreaking. I think that is the reality of it, is that the overhead is extremely high. And so I hear from providers all the time, especially during the pandemic. I heard from a lot of providers who dropped from the network who were really upset about it. But they said, I can't be financially sustainable in doing this. And I've heard from some providers, they get pressure to cut corners or for their Husky patients to do shorter visits, to not do all of the steps that you would do, which is really disturbing as well, because we want to make sure that people on Husky are getting high quality care. And of course, there are providers in the network who are providing that high quality care, and they're just taking the financial hit.
Yeah, I know our local FQHC here in Norwalk has a pediatric practice, and it's been doing great things. And so it's difficult to hear. And I understand I sit with Rep. Abercrombie on appropriations. And so, there's a lot of competition here for dollars, and we have a limited supply. So I appreciate your testimony, and thank you, Madam Chair, for your indulgence here.
No problem. Thank you for those questions, Rep. Dathan. Rep. Abercrombie, I saw you put your hand back down.
The only thing I was going to add was, just so my colleagues understand, we're one of the few states that offers Medicaid for adults under Husky, right? Most plans in other states don't. So, when you try to do apples to apples, keep that in mind. A lot of states don't offer dental under the Medicaid program because you don't have to. And give you the flexibility, and we're a state that has always been proud of that. Yes, we're number one when it comes to the kids. Yes, we can do better with the adults. But as my good colleague, Representative Dathan, who's also on approach, just said, there's only so many dollars to go around.
Yeah.
Doing the best we can with what we have.
Yeah. Thank you, Abercrombie. You are right. It's an optional benefit, which I think is a big problem in a federal law that needs to change. There are actually, I believe, 32 states that do offer adult dental services of different amounts, right? So some have more limited services and some have more expansive. And we're on the more expansive side, although we do have some big service gaps. For example, gum disease treatment is not offered to people on Husky, which is a big problem. But thank you. I do understand, and I do understand and respect that. Thank you.
Thanks, Rep. Abercrombie. Thanks, Parisa, for your testimony and for your time with us today. Are there any other questions or comments? Because I believe, unless any of the people who were not on when previously called have joined us, Parisa is our last participant to give public testimony.
So Representative Leeper, if we could just turn it over to Heather for one moment, just to tell us when our next meeting is and what we've got going on, that would be great.
That would be great, Heather. Thank you so much.
Thank you, Madam Chair. So the next committee meeting for the Human Services Committee will be 1 week from today at 9:00 a.m. and that is March 8th. And that day we will also be having our second public hearing at 11:00 a.m. And you will be receiving invitations from me for both those events. And as always, please let me know if there's any additional information you might need. Thank you, Madam Chair.
Thank you so much,
And
Heather, for that update. Oh.
I just want to take this opportunity to thank Representative Leeper. You know, with Senator Moore and I having to be in two places at once, I just want you to know how much we appreciate you being able to step in and help us out. We really do appreciate it.
Happy to.
Representative Leeper, you did a yeoman's job.
You
sound like you've been doing it like 10 years. You did a great job.
Thanks, Senator Moore.
Thank you.
Does
and with
anyone
that, we can close out this public hearing for the Human Services Committee. Thank you, everyone. Enjoy the rest of your day.